What if the problem isn't in your eyes, but in your brain? What if the hearing loss you've been ignoring, the personality changes your family keeps noticing, the headaches you keep dismissing, or the depression that doesn't seem to improve are all signs of something growing silently inside your skull? Every year, thousands of people are diagnosed with brain tumors. And contrary to what many believe, most of these tumors are not cancerous. But that doesn't make them harmless, because inside the skull there is no extra parking space. The brain lives inside a closed box, and when something begins to grow in that space, even slowly, it can begin to compress the very structures that allow us to see, hear, speak, swallow, balance, remember, and even be ourselves. In this World Brain Tumor Day special of Rebooting the Brain, we are joined by Dr. Suresh Dugani, one of the India's pioneering skull-based neurosurgeons whose work has helped shape the evolution of skull-based surgery in the country. This is a field where anatomy, technology, and the surgical judgment meet the most delicate crossroads of the human body. A place where a tumor may sit millimeters away from the vision, hearing, speech, swallowing, or the brainstem itself. But this conversation is also about the journey of a surgeon, a journey that took Dr. Suresh Dugani from Nimhans to Hubballi, where he became part of building advanced neurosurgical care for patients who needed it the most. Along the way, he learned that in neurosurgery, skill matters, but so do patience, judgment, composure, and the ability to stay calm when every decision can change a life. In this conversation, we explore what the skull base really is, why tumors in this region are so challenging, and how modern surgery has transformed outcomes that once seemed impossible. Through remarkable real-life stories, Dr. Suresh shares how brain tumors have masqueraded as psychiatric illness, depression, hormonal disorders, hearing problems, and even simple changes in behavior, sometimes for years before being diagnosed. We discuss the warning signs families should never ignore, the importance of early detection, the evolution of skull-based surgery, and how today's neurosurgeons balance a difficult question. Not just can the tumor be removed, but can the person be preserved? Because modern neurosurgery is no longer about removing the maximum tumor. It is about preserving the maximum life, from anatomy to awareness, from technology to humanity, from diagnosis to dignity. This is a conversation about seeing what often remains hidden until it changes everything. This is Rebooting the Brain, and this episode is a reminder that the brain often whispers before it screams.
ज्ञानानन्दमयं देवं निर्मलस्फटिकाकृतिम् आधारं सर्वविद्यानां हयग्रीव उपास्महे हयग्रीव उपास्महे.
Rebooting the Brain, powered by PRS Neurosciences.
Namaste, everybody. Welcome to another edition of the podcast Rebooting the Brain. Today's topic is called Mission Impossible. So you must already be getting triggered of what's going to happen. So you have to hold your horses for some time. Let's start with the mantra. Om Asato Ma Sadgamaya Tamaso Ma Jyotirgamaya Mrityorma Amritam Gamaya Om Shanti Shanti Shanti. As this shloka says, from ignorance to enlightenment, from darkness to light, and from death to immortality. This has been one of my favorite shlokas since I was a child. You can use this in any part of your life and get value. Try it, guys. So before we go to the guest of the day, some housekeeping rules. Don't forget to subscribe to our podcast channel, Rebooting the Brain, on YouTube, on Instagram, on Facebook. Please watch all our videos. We have some fantastic content there already. People are loving it. And once you watch, please don't forget to subscribe, like, share, hit the bell icon, and most importantly, put generous comments. Your comments will help us to push it to more people, and more people will get enlightened with what is going on. So, we introduce the Mission Impossible Man of the Day. Let me welcome Dr. Suresh Dugani from Hubballi, India. Sir, welcome to our podcast.
Thank you, Sharan. It has been a real pleasure and honor for me to be with you this nice morning and interact with our subject and be a small part of your mission, your endeavor of spreading the neurosciences all over the globe, making them aware of the common neurological problems, neurosurgical problems, and the treatment of these are today's scientific world. We can give 95 to 100% excellent outcome in these patients. There are few disorders where we cannot be helpful. But I'm sure you are a very senior neuroscientist like me. We are, many of us all over the country in this. Almost I personally feel 80 to 85%. We can today, with the modern advanced technologies, applications of this techniques and what is available today in diagnostics, imaging technologies, we can really do wonders in treating these people. And most important is we can give back to the family, a society, a country, a productive individual, which otherwise in the past was not possible.
I totally agree with you, sir.
That's what it is. And really, I'm today, let me be very honest. I'm so glad and feel happy to be a small part of your endeavor, what you are doing.
Thank you, sir. Thank you so much.
Thank
Sir, you are, by yourself, you have educated all of us online. We'll come to that a little later. But you just watched the video before we started.
Yes, sir.
Of Tom Cruise, an actor, familiar and, probably like both of us like. He's coming downwards, head down first, and trying to make a heist in that movie called Mission Impossible. And now he is the Tom Cruise of neurosurgery. I call him. He didn't like it, but I'm saying you are, sir, because you have a passion for something that we're going to talk about today, guys, called skull-based neurosurgery. Now, this is very nice and smooth. The bottom is exactly the opposite. It's anything but smooth, anything but thing. So, like how Tom Cruise came down and looked at all the lasers, all the security cameras, and everything else. Here, we encounter cranial nerves, major vessels, the brain stem. You cannot imagine what's happening. And inside, intertwined all of these things, one dirty-looking tumor will be sitting, and we have to take it off. Sir, skull-based neurosurgery.
Before that, thank you, Sharan, for comparing me to that. But it humbles me, and we're a small part of the
sir,
system and surgery.
What you have done, we know, sir. So
thank you.
Please, guys. I was thinking, what should be the apt way to get into this podcast, and that's when last night 11:30 I got this idea. I was thinking, how is it, and then. Till then, I couldn't sleep, I was just trying to crack my head.
I know your commitment, Sharan. Thank you.
Welcome, sir.
Thank
you.
Thank you
so much.
Thank you very much.
Sir, let us start with the fundamental question.
Yes.
What is the skull base?
Yes. See, the face, the whole thing, face and skull, they're joined together.
Correct.
Right?
Correct.
Where the face ends, the skull starts. Right? So, scientifically, anatomically, physiologically, the zygomatic arch on the lateral part of the skull,
Correct.
where the lateral part of the eye goes backwards at the level of the ear outside. Below that is called face. Above that is called skull base and skull.
Got it.
So the treatment of skull base is at this juncture between the brain up and face down,
Got it.
right? So
Got
that
it.
we call it a skull base. Why it is so important?
Yes, that's the key.
Yes, why it is so important is it is a boundary between the deep superficial and a deep part of the face and the boundary between the brain. So in between this area is located. Now what happens is more than almost all cranial, what we call cranial nerves from the brain, they cross the skull base and come out to supply the face, the facial structures, eyes, ears, nose, eating, swallowing, breathing.
I'm not even sure how many of them knew this, how many of our public realize in
Exactly.
such a small real estate, so much is going on, sir.
Exactly.
So much is going on.
Exactly. And majority of our neurosurgical, say about 30 to 40% of our neurosurgical problems, they occur at that level, that we
Correct.
call it as a skull base level,
Correct.
where the location is so important and vital. Preservation of these nerves, preservation of blood vessels from the heart, they go into the neck, then they go to supply the brain. When they go to supply the brain, they cross through the skull base. They cross the skull base, they form a vascular territory or vascular junction, to tell it in a common man language. A common territory is called circle of Willis.
Correct. Circle of Willis. Right.
From there, all the blood to the brain goes from there. So majority of these skull base pathologies, they are around this cranial nerves, 12 pairs of cranial nerves. They are around the blood vessels which supply the brain. And important structures like optic nerves, where you can see
The vision. Yeah.
vision, eyeball movements, where you can hear, you can taste, you can smell. All these structures are located at that juncture. So treatment of this makes really challenging to you and me. Skull base, I mean, there are all over the world where skull base separate section of people makes it challenging.
I agree. Now you see why I call it. It sounds mission impossible because, guys, it's not like a car. You know, the bottom of the car has all this, but you can't lift up the car and go down and look at it. You can't look at the skull base like this and see what's going on. Yes or no to that, sir is going to tell you how he does look at it. So we are going to go there, but that is what has been technically challenging. And then also, the skill, as much as technology is there, sir, this and this is the most important thing for us to know what to do. And most importantly, we're going to learn from you what not to do.
Exactly.
It's very, very
true.
important for you to give enough messages to the public and the budding neurosurgeons and everybody else what not to do when you're a good neurosurgeon. Great start to that.
Thank
So
you.
now, how do you categorize the skull base? Is it all one piece, or do you break it up into different parts so that then we can go step by step to each of those parts?
Right.
Sir?
You're absolutely right. See, for treatment purpose, number one, for the pathological occurrence purpose, plus anatomical purpose, we divide the skull base into three locations. One, the one which is in the front of the head, just above the eyes, we call it as anterior cranial fossa. Right. Just behind, at the level of the ears, just behind that, in the center of the brain, on the sides we call it temple area on the sides. We call it as middle cranial fossa. Behind that, where it goes behind the ear, up to the upper part of the neck, we call it as posterior cranial fossa. Right. So, why you divide this? The pathologies, the problems occurring at front level, for the mid level, for the back level, they are in a different location, different types, different locations. Involvement of the structures is different. Not that one is important, one is not. All three are equally important. Equally
All three are different.
different.
Three different stories happening there.
Exactly.
Just because you're good at here, you can't automatically be good at this place.
You're
as an
absolutely
example.
right. Absolutely right. So each one of them have their own speciality of reaching there, operating there, and giving the good results. Each one is extremely challenging. So when you do all three as a surgeon, you can call yourself as a skull-based surgeon, and it's really challenging. Really challenging.
Absolutely, sir.
Thank you.
So, what got you interested in skull-based surgery?
Yes, Sharon. Yes. No, this is very important question you have asked. Very important
Like,
question.
I'm a functional neurosurgeon, sir's passion is skull-based.
Yes, thank you. It is a very important question you ask. See, my liking goes back to 1980, 88, 89, 90, 91, in those
Okay.
areas. At that time, it was evolving.
Correct.
Then what happened is, I was working in Hubli Dharwar area at SDM Dental College. We had established a department called Craniofacial Skull-Based Department in 1991.
Craniofacial
Skull-based department.
Exactly what you described, you have made a department. Perfect.
Thank you.
Perfect.
Yes. There is a very senior craniofacial surgeon, Professor Bhaskar Rao, Paul Salins, Dr. Gopal Krishna, John Jeman, and various skull-based people. They were all trained in the West and recognized this as a challenging branch. And with the infrastructure given by the society, the STM society, we started Department of Skull-Based Surgery 1991 in STM.
So that you must have been pioneers at that time, no, sir?
I am not very sure, but we started doing that. Yes.
Amazing.
Yes.
I'm not even sure whether it was existing in Bangalore as a dedicated unit like that. I don't think so, sir. Not that I can recollect.
That's right.
Yeah.
Then what happened is, we used to operate these, what I mentioned to you, skull-based lesions through the transfacial.
What do you mean by transfacials?
We used
For
to
the sake of the audience.
Yes, we used to split the face.
Oh, like this.
Either we had multiple sections. We used to start with the Weber-Ferguson incision, lateral face split, or you can split the face in the midline, mandible, and open the face. Access the pathologies in the anterior and mid skull base and close the face.
Amazing. It's like opening a door and closing a door, but not as simple, but it's possible. That's why I always say, sir, God has designed this human body for surgeons.
Exactly.
You don't agree, sir?
100%. I agree with you. It is.
So amazing.
Amazingly.
Amazing.
Yes. So this was very, what you call, interesting and challenging. That created a lot of interest and challenge with the team, what I mentioned to you earlier. And that's how we started.
So I think it was God meant it to be that you had all these people sitting there and you came in as the key person of the team, and then you put the whole story together.
One of the person, one of the team member.
Yeah,
that's
agreed.
it.
Because the neurosurgeon eventually will have the...
And believe me, Sharon, we did amazing work at that time, 1991, yes. See,
skull-based support was also not so much technological.
Exactly. Skull-based angiofibromas, skull-based schwannomas, skull-based meningiomas, ossifying fibromas, nasopharyngeal carcinomas, where they involve the face and involve the brain also, both the locations, both of them.
From down it starts eating
Down
up.
used to start and go. That's how we again started doing the. Now few cases had to be done from below, and few cases we had to do it from above. So we developed this and started in 1991. And as every day, in those days, as you rightly mentioned, probably there are very few centers in our country.
I think so, sir. Dedicated like this.
Yeah. So that became within about 5. Professor Paul Salins and all that I mentioned to you earlier, very, very, extremely good and committed and good.
Correct.
So what happened is the references started coming to us from vast areas. So that helped us to, and in those days, I would like to bring it to notice that we had a British skull base and neurosurgeons, German, Polish,
Where?
and
There in
American.
Hubli?
Yes, they used to come to Hubli Dharwad. They used to stay with us for 3 months.
Really?
Yeah, they stayed with us for 3 months.
I didn't know this at all.
To 6 months. They would stay back.
Whoa.
And train us. We work with them.
Amazing.
And British senior registrars, British, they used to visit us as visitors, stay with us, work with us, and learn back. And that's how we started our own the senior registrars in maxfacial skull base. We used to send them to Europe and get them trained.
I think it's like me saying you're the chosen one. I don't somewhere, it could have happened in Bangalore, it could have happened in Mumbai.
Yes.
It happened in a place called Hubballi, and that was 1990.
Hubli Dharwad.
Yes. Your foray to Hubli is a different story, so I'm going to come back to that later.
Thank you.
We'll stick to skull base now.
Yes, Sharan.
So
yes.
Let us start now that you're given a very beautiful description of what the skull base is and how you approach it. So the automatic question to everybody is, how do I know that I may be having a skull base tumor? That means what symptoms or what are the things that I will start suffering from that makes me to be worried or should be concerned and seek help from the right doctor?
Very, very important the question. Very important. Because most important here is in this skull base lesions is picking them up at an earlier stage.
Well said. Agree.
Okay. Because they involve a very, very complex area of the brain and skull base. So picking up them is very important. So
where they're still small, so it's
Exactly.
easier to operate or
Very
do
good.
whatever treatment.
yes. So few clinical things I would like to
Sure, sir.
share with our colleagues, our medical colleagues, and even through your the excellent scientific media, what you are projecting to the lay people also, is that whenever there is a visual disturbance, seeing, like you start seeing two objects,
Double vision.
or your vision slowly goes down. Number when sometimes people may start losing smell. Some people start hearing less on one side with ringing noise in the ear or imbalance. Some people may develop, they may come with speaking up difficulties, talking difficulties, swallowing difficulties, and they develop headaches, headache in the front, headache in the back, and these are the common symptomatology they come with. So whenever they come with this, we should take them very seriously and investigate them.
Can you give one or two examples of some patient story who came in late, neglected himself, anything like that? You can warn them, because also before you come to that, see, I want the audience to know that brain has the highest number of non-cancerous tumors. Most people think tumor equals cancer equals hopeless. this is this normal equation people think. A non-cancer, even if a big bump here, nobody cares. It's just there. But in the brain, even 2 centimeter tumor in the wrong location can be disastrous in more ways than one. That's why sir is saying you have to catch it early. And he is talking more about non-cancerous brain tumors than cancerous brain tumor. So now, if you give some common tumor examples, how patients walk into your OPD or brought there, however it is, so that how does it go, sir? Has it changed in your practice over 30 years? Are people coming? Any wisdom has come, or is the same hopeless situation, sir?
You were absolutely very important question you have asked, Sharon. First thing, see, for the lay, for our lay people or society, community, even our non-neurosciences medical fraternity, not all brain tumors are cancerous. We would say about 30 to 40% of the 30% to or so could be cancerous. 30 to 40%. Two types of cancerous. One is cancerous tumors in the brain itself. They grow there. Second, some cancer anywhere in the body, like lungs, like abdomen, like colon, like breast. From there, the cancer spreads to the brain. We call it as metastasis to the brain. So primary cancerous, secondary cancerous, they make about 40% of the brain tumors.
Only 40%.
40%. Remaining 60% of the lesions in the brain, they can be non-cancerous.
That is the single first biggest message we want the audience to get, sir.
Very true. And these lesions, if you recognize them early in their occurrence, understand them, and if you can treat them with a good technical things, technology, technical applications, a good center, believe me, we can help these cases to 90% of the time. We can give back the family, we can give back the society a normal working individual.
Amazing. Very well said, sir. Thank you so much for making this statement, because
Thank you, Sharan.
people think brain surgery means finished. Mars ko bekar, last, and there are a lot of well-wishers around them who say, Mars ko bedi, it's like this, it's like that. For whatever reason, sir is saying very clearly that it is not only possible, but at the end of the day, there are people who have gone back to their level. I'm quite sure in your own practice, there are so many people coming after 20 years, 25 years, completely all right.
Absolutely right. Absolutely. Phenomenal.
And that is 25 years, 30 years in somebody's lifespan after major brain surgery is like incredible, sir.
Very true.
Incredible.
Sharan, this was, I'm talking 30 years back, which I came through my journey of my neurosurgical life from 1990 till about that. But today, last about 1.5 decades, what the technology has grown, be it diagnostic, be it management, be it pharmacological, be it intensive care, be it electrophysiological monitoring, we are able to give much advanced, much better care, much better outcome to these patients.
We would not want to say 100% because we are not gods, because risk is there.
You're
but
right.
Truthfully, if you look back and see, sir, they're only getting better.
100%.
Sir, but, a big but, B-U-T, they should come to us in time.
Absolutely right. That's very important.
Yes.
Very, very important question. See, many a times, that's what you are doing is a really a great service to the society. Great service. Recognizing them early,
correct,
makes a lot of difference.
Absolutely, sir.
Because they are small, technically.
And they grow slowly.
They grow slowly.
Correct.
And as a people who are treating them like me and you, it is very quick job, simple job, and most important is safe for the patient. Right? So there are so many examples, so many things we see them. They know they are not recognized. A simple example I can
Sure,
give
sir.
you. There's a meningioma of the skull base.
What is a meningioma, sir? Let me ask you a fundamental question.
See, the brain has 3 coverings. Like my body. I wear a coat. second one is shirt, inside is a innerwear. 3. Like that, brain also has 3.
Very simple example.
Very simple, right? So outside, the one which after the skull, after the bone, skull bone, the first one is, we call it as dura mater, like my coat, dura mater. Inside that, there is one more layer, we call it as arachnoid, a thin arachnoid matter. Inside that, on the surface of the brain, adherent, stuck to the brain, we call it as pia matter. These 3 layers. It's a natural, every human being, practically every individual has this type of an arrangement, which is the brain, the protective layers. So meningiomas arise from these protective layers of the brain: arachnoid, pia, and dura. So that's why they are called meningiomas, meningeal openings, meningiomas.
Got it.
See, this person was, I remember this about 20 years, 25 years back. He was a farmer and a middle-aged person. He started behaving abnormally.
Behaving
Abnormally. Because tumor was on the left side of the brain. Speaking abnormally. Talking irrelevantly. Understood. These were the manifestations.
It sounds more psychiatric, no, sir?
Psychiatric. Yeah, absolutely right. Then the family. Exactly. This is exactly what happens at the periphery. Then he was taken to the psychiatrist.
Oh, that's happened.
They took him to psychiatrist. See, in those days, the scanning facilities were very less.
I agree, sir.
Very less. And again, what happens is the behavioral, his complaints were so, towards that side. They started treating him, and this went on for some time. He didn't recover.
So the psychiatrist treated him.
Continued to treat. Then one fine day, when he was in the psychiatrist clinic, he had a convulsion.
Oh, epileptic fit.
Epileptic fit. He developed a fit and became unconscious.
Okay.
Then they took him to a scan center. Then they did a brain scan at that time. There's a big, huge meningioma of the skull
like a football. Must have been like a football.
Like an apple. Apple. Big meningioma. Right. It had grown up over 5 years.
Correct. This psychiatric treatment went on for 5 years, sir?
5 years.
My goodness.
Yes. No, that you cannot.
I can't. No, I know. I'm just expressing as a neurosurgeon.
Yes.
It's frustration, bewilderment, whatever.
Then he was referred over to us. And we took almost about 6 hours or so. It was arising from the sphenoid wing.
Last week we did one, so middle sphenoid wing.
Right. Middle sphenoid wing on the left side. So that was the cause of his behavioral changes, what he had. Then we excised it, and this we did about 20, 22, 25 years back. He's perfectly fine. There is no recurrence. No coming back of the tumor.
No chemotherapy, no radiotherapy. Very rarely we give radiotherapy if some residual tumor is there, some recurrence happens. Otherwise, it's like a cure, like you're saying.
Absolutely.
Amazing.
Right. This was the few things. We see them very often.
Yes, sir.
Very
Yesterday,
often.
I saw one case, sir. Last week he came, very obese guy, very comorbid, poor heart function, everything else. He came with difficulty to walk, imbalance in that fat fellow has fallen twice. And then they imaged him, and then they realized he's got a CP angle tumor, which is an acoustic vestibular schwannomas. Then I asked him, I said, did you have problem hearing? From last 2 years, he's deaf.
You can imagine.
So now sir is saying behavior, I'm saying deafness, we are saying tumor.
Yes.
Can you imagine, guys, how complex the skull-based tumors are? Each one is singing a different song. Which song is related to us, which is not related to us, we should not know. So you should get aware of what's going on.
Exactly.
So what is a vestibular schwannoma, you tell us, sir?
Yes. They see, we have a hearing nerves.
Correct.
We call it as initially I told you, anterior cranial fossa, middle cranial, and posterior skull base. This is situated in the back of the head, back of the neck, behind the ear. We have 2 important nerves. We call them as 3 important nerves. Facial, which controls the facial movements of one side of the face.
Like when you have a facial pulse, like how our Chief Minister, ex-Chief Minister Bangarappa had what we call as Bell's palsy. That same nerve he's talking.
Weakness of the face. You see them, that face becomes deformed. That one. Along with that nerve, we have balancing nerve.
Correct.
We call it as vestibular nerve.
Correct.
Where all our balancing in the day-to-day life is controlled by that
Correct.
nerve. Just attached or along with that nerve, we have hearing nerve. That's what we call cochlear nerve. So all these three nerves go in one bundle.
Correct.
Called 7th, 8th and 9th. I mean, 7th and 8th complex. Vestibulo-cochlear complex. Right? So the tumor, this acoustic tumor, otherwise called as
Correct.
acoustic tumor, otherwise called vestibular tumor, cochlear tumor, any different names are there. These nerves have covering.
Like an insulation.
Insulation.
Correct.
We call them as Schwann cells.
Correct.
Schwann cells, which go onto the nerve.
Correct.
These tumors originate from 8th nerve, that is vestibular nerve. From there, Schwann cells. It originates and becomes slowly. It's very benign. And suppose if I am seeing on the scan, say of a size of 3 centimeters tumor.
He was exactly 3.2.5 by 2.3 was his size.
Right. So that tumor has started almost 10 years back.
10 years.
Slowly. 1
So
millimeter.
10 years people had time
2
to.
millimeters. Exactly. That's exactly what is importance of what you are
Correct.
propagating. Recognize early. When it is small, everything is good. Your treatment is good. Outcome is good. Patient is safe and comfortable. The amount of efforts the family puts, the amount of effort as a doctor, as a surgeon you put, returns are very good. And many of them, they don't come back again.
I agree with you. Many of them we meet in some function or
Exactly.
somewhere else.
Exactly.
They can't bump
Yes.
into each other on the road
Very
rather
true.
than anywhere else.
Very true. Very
Compared
true.
to somebody with a cancer.
Yes.
So
yes.
since you said this 10 years of the vestibular schwannoma or acoustic schwannoma, what we say, what could be one of the earliest symptoms? Like if you want people, see what will happen sometimes is there are one set of people who get paranoid. They do the googling and then every symptom they'll think I have a brain tumor. That's one extreme. Other extreme is until they can't walk, they fall down, they think they have their. So in between, what is a rational way of thinking when you have a set of symptoms and how to do
Very
it?
important question and very practical what you ask. This is every day we see
Exactly
in our lives.
Exactly.
Of late.
Yeah.
I'm sure
Yes, sir. Yes,
everywhere,
every day. Yes.
each one of us, every young educated fellow, either a techie we call software engineers, all of them come with Google doctors.
Correct.
Right?
Correct.
They imagine the symptoms, go to Google. Now next step has come, ChatGPT. Even it tells you the treatment also.
Correct. Whether ChatGPT is hallucinating or not, we don't know, but anyway,
Exactly.
treatment is coming.
So that is one set, what you said. Other set of people, when you asked a very important, pertinent question to these patients, is that first, especially vestibular schwannomas, they come with two important manifestations. Early symptoms. One, slowly diminished hearing in 1 year. Number two, slowly coming up vertigo, giddiness, swaying on one side. So these are two important complaints if you are having. Now what happens is, majority of the time, they go to ENT surgeons. And if the ENT surgeon does few investigations, like most important is audiometry, your pure tone audiometry. On audiometry, if there is a significant or some amount of sensory neural hearing impairment
or deafness
coming down, all these patients, unless proved otherwise, you must have an MRI or a contrast CT scan, contrast MRI scan. That will pick up the lesion very early and you can treat them better.
So
and today's world, just I want to add.
Sure.
today's modern neurosurgical world, with advances in microsurgical techniques and intraoperative electrophysiological monitoring, we have reached the stage in a schwannoma, if it is a small size, we can preserve the hearing.
Hearing preserving surgeries talk about. So the symptom you're saying is, so when I get patients like this, when I've come much later in that whole thing, I ask, "Kivi yavatenda kelistala," I mean, they'll say whatever. Then automatically what they've done, I have to ask the next question. When did which year do you use the phone?
Exactly.
And then they'll say very always, "Illa sir, modla used to hear like this." Some problem, he has not even realized that he has made this unconscious change without realizing, sir.
Absolutely.
So can you imagine?
Absolutely. You're
I mean,
right.
sometimes
You're
I
right.
wonder, I mean, is this really?
Yes.
Why would
Especially our Indian
Allah, sir?
Indian. See, the Westerners are very particular.
Ah,
But see, acceptance rate in our country is very
I,
high.
I,
You're
I
absolutely
agree,
right.
sir.
This country
Oh, he's continuing because gadi orta hai, he's going on.
That's right.
I said, Illappa, did you realize there's something going
Sir,
on here?
ಮೊನ್ನೆಗೆ ಹೋಗಿ ಕಿವಾಗ ಸ್ವಲ್ಪ ಎಣ್ಣೆ ಹಾಕೋ. You understood. This is exactly what happens.
We are trying to tell you guys, you don't think we are laughing because we are trying to get you guys to understand. It's such a simple thing. But you have to understand, don't get it into your head because these are non-cancerous tumors which we can fix. And sir made an important thing. If you go for a scan of the brain, get an MRI scan with an injection called contrast. Sometimes plain scans can miss it.
Exactly.
Especially if it's very small, sir.
Right. True.
Especially if it's intracanalicular, if somebody is not searching for it, they will not even find it, sir.
Very true. Absolutely. Which is, once you do that, and if it is there, fine. If it is not there, next 10 years, you don't have to bother.
Exactly.
You don't have to bother.
Yeah. So,
continue with the medicines.
Yes.
With the ENT or whatever you want.
So, now I'm going to add some very interesting. Our first podcast was with Dr. Vikram Hude.
Right.
On stroke.
Right.
He made a statement. Sir, all master health checkups illinda kedage, sir. Nobody is worried here at the end of that.
You are absolutely right.
The neck and the brain is out of everybody's purview at the end of the day.
You are right. Absolutely right.
So what sir is also saying is the same thing. If you can't, something is happening, some ear ringing. I mean, 90% of the time the scan could be normal. But unless you do the scan, you don't know whether it's going to be normal. It's like until you do a blood sugar, you don't know whether blood sugar is normal. So it's the same way. We are trying to inculcate it very, very easily that it's available. So now MRI scans are available everywhere.
Everywhere. Yeah,
literally.
Right. Yes.
It's not complicated like earlier. I think your training must have been pre-MRI scan era, no?
100%.
Then
when we were trained, we didn't have an MRI. We had only CT scan.
CT scan, exactly. So I think we have come so far in one lifespan that we are seeing so much. I was watching a video recently of Anupam Kher.
Right.
He was telling, I think this generation, from his generation to probably our generation, is the luckiest generation, it seems.
Yeah.
Because we have seen that maximum, progress from, where we were to where we are today, and we have enjoyed this whole journey.
Very true.
So we are saying that we are probably one of the luckiest generations. Something he was making a statement.
Agree with you.
Don't you agree, sir?
100%. No doubt about it. No doubt about it.
So he was saying that.
That's very nice.
Yeah. So we now spoke about one story from a middle cranial fossa. We spoke about a story of a posterior cranial fossa. Can you give a story from an anterior cranial fossa? How would they present that you would do so that we have all three covered?
Yes, sir. See, the anterior cranial fossa, midline or basal lesions, few important symptoms one must remember to the patients rather. One is the smell starts coming down. Smell. Okay. One. Either it comes down or they go to I've seen many a times, ladies especially, the normal smell, earlier what they used to smell, a normal smell, they start perceiving abnormal.
Okay. Abnormal means bad smell?
Bad smell. Like say the cooking smell, masala smell, or they use perfumes, they use cosmetics, the smells are there. Slowly they start feeling this is very bad smell. Why I'm getting this bad smell?
And they stop using that perfume and change the perfume.
Exactly. That's another important thing, that there's something wrong. You must be investigating.
All these sensory nerves sir is talking about.
Next is the vision we mentioned earlier. Slowly the one eye vision starts coming down. Now what happens is Once the vision starts coming down, first thing they do is go to the ophthalmologist,
Correct. Eye doctor.
eye doctor. Believe me, Sharan, many of the anterior cranial fossa, middle cranial fossa pathologies, what we have got, they're all referred from a very good ophthalmologist to us. Very good ophthalmologist. First time they go, they check the vision. Vision is less, correct it with glasses. After 1 month, after 2 months, go back again, vision is not corrected. In spite of glasses, change the glasses. And various changes they make.
Correct.
Still, after another 2 weeks or month or 2 or 3, still there is no change. Then, if your glasses are corrected, given, still your vision has not improved, you must get a investigation. Either a CT scan or an MRI scan.
Sir, I'm going to push back at you for
Yes.
this, I'll tell you. In the last 2 years, 2 of the pituitaries we operated, 30, 35-year-old guys, sir, IT professionals, sir. IT professionals. That means educated,
Exactly.
computer.
Yes.
They're only on the computer, they can Google anytime. You know,
Correct.
it's literally not like people
True,
like us, we have
true.
to go out to a place to.
True.
Dense field defects, sir.
Yes.
Dense means I was actually disgusted. I said, what are you doing? Yes, sir. He could see the screen. He didn't bother. He didn't realize that the rest of the field, he could not see, but he didn't bother, sir.
Exactly. I'll tell you one more story of a lady. She was MA PhD
Huh.
in Karnataka University.
Sure, Ramachandra.
Very high post. Okay. And one day, when she was traveling in the car with her husband, window was down, there's sudden wind blowing, lot of dust, some road repair, came inside the car, went into her eyes. And she closed one eye to clear
Whatever.
it.
Huh.
Other eye, she could not see.
Sure, Rama. Are you serious?
I'm telling you.
What?
Yes. This is exactly what happened.
My goodness.
Imagine this educated MA PhD lady
Sure.
as a very good executive post in the university.
With a 5G phone.
Yes, with the Karnataka University.
My goodness.
Never noticed the loss of
Sir,
vision.
how is that possible, sir? I'm not able to digest this, sir.
Understood?
Huh?
This is exactly what happens in our
What
country.
Loka? See, you understand where we are. Yeah,
Yes.
Patara Loka we are, sir. Neuroscience people under. I can't imagine this, sir. That's much worse than what I was telling you, my story.
See,
Oh,
I then
my
when she
goodness.
came, they brought to her, to us. Then she went to ophthalmologist, and rightly, accurately, he investigated with the MRI the huge pituitary adenoma. Anterior skull base meningioma. Then I asked her, see, you noticed this vision coming down yesterday, day of yesterday, when your dust fell into your eyes. You were having bath every day,
Correct.
washing your face and
Correct.
this and that. Didn't you notice this before? No, sir, it's happening for quite some time. But I thought the dust has fallen down, water has gone into the eye, soap has gone into the eye. And these are the explanations
From
they
an
give.
educated person.
You understood? This is exactly
And
what happened.
if this person with this level of ignorance knowledge goes to Google and put this information, I mean, they'll get some nonsense output, no, sir? Because if you
Exactly.
put garbage in, you'll get garbage out as a
Very
response.
true.
Because
Very
those
true.
those engines don't think, they'll only, based on what you give, it'll give you some answer.
Absolutely right, sir.
Huh.
See, what is happening today, I'm sure all of us, not only
Correct.
me, you,
Yes, yes.
all the medical fraternity is observing the younger generation with the technology, software techniques. Whatever happens, first thing they access is Google. They
It's
type.
not wrong, but they should not take Google is better than us or
Exactly.
whatever it is. Huh.
They I'll tell you the story also. They go to type whatever they come, headache, vomiting, and they suddenly it gives brain tumors. Understood? And they come back and last week only it happened that a fellow had come and he said my blood sugar is this much. You are not a diabetic, and this is going on for 6 months. blood sugar 180, 120, HB1AC, this much. And he kept on went on Google. Then I said, do you are getting a blood sugar done? Why didn't you go to the doctor? No, sir, I used to search on the Google and this is what it said. Then suddenly he developed vision loss in the one eye.
Pituitary.
No, retinal detachment, diabetic retinal detachment. 6
What
months.
are you saying? Really?
Yeah. Then he became with a blindness.
Shit.
And Google is telling him this is sugar is okay. They don't worry. Sugar. Then I said, you do one thing. You go to Google back. Tell that you have lost a vision. What shall I do? And get the treatment from Google only. Don't come to us. It's your mistake. See, if you go by technique, all this, yes, it is fine. If you think it is well, but you should not put your health things on
Alva, sir.
on that. It is not right. That's
It's
what is exactly what's happening.
Sir, I asked one patient the same question. Illappa, forget this. You may be saying you doctors. Chalo. Will you ask Google and ChatGPT to invest? And if you keep on losing money, we'll continue to invest. I mean, correct, no, sir?
Exactly.
The
That's
money
right.
seems more important than any of this thing.
See, there
But
must be
could
some.
have
You're absolutely
some
right.
moderation at the end of
There
the
should
day.
be some understanding.
Yes.
And to some extent it helps, but the majority of the time, where the specialist available, what is your health is actually very much important. See, for no reason you lost your one eye,
Imagine, sir.
which is going on for 6 to 8 months.
Crazy.
For no reason. He's a young
Crazy.
fellow. He must be about 60, 55, 45, 50.
What a
This is
tragedy.
exactly what is happening.
I want to push back on the ophthalmologist, sir.
Right.
I wanted to ask, I need to ask the ophthalmologist, like I'm asking about how they don't do this. Why? Two things are happening today, sir, in eye test. Number one, most of the times that optometrist is doing the eye test, sir. Many places there is no ophthalmologist, the patients don't even see an eye doctor. So they go to, many people don't even know the difference between the guy who's testing to the eye doctor.
You're right.
Correct.
Absolutely.
Correction ಕೊಟ್ಬಿಡ್ತಾರೆ, they go home and that is going on.
Exactly.
And
they give the glass and they happily take it
They
back.
take it back, but they say they've gone to ophthalmologist. Many times when asked, they said they've not even gone to ophthalmologist.
You're right.
This is
Absolutely.
the first thing.
Absolutely.
Yeah, and in fact, even I don't know whether it's available in Hubli, but today there are people who come home and do an eye test, sir.
Okay, I don't know that.
Really?
Really? Okay.
They come home, sir.
Okay.
They come home, they set up the Snellen's chart and all that stuff. They measure 6 meters. They make
Okay.
you sit there, tuck, tuck, tuck at the marble.
Hmm.
And manela specs are over there, sir. So that is also happening for the
Yo,
convenience.
That's
of
the next level.
next level, sir.
Right.
But more importantly, I don't see them doing routinely the visual fields.
Exactly.
Why is that? I want to, because I've been asking some of them. I said, why don't you make the visual field confrontation?
That's
I'm not asking you to put the, at least we pick it up confrontation on the OPD, sir.
Very
It just
true.
takes us less than a minute.
very true. And fundal examination.
Yes, fundal.
examination.
Fundal, I'm assuming they're doing, sir,
That's
but the confrontation of a visual field
True.
is something that they don't
They have
do
to.
routinely.
That's right. So these are the few things. Number one, and again, sometimes the one eye gets proptosed,
Oh, bulged.
because of the lesion inside compared to the other side.
Agreed.
Number. Next, most commonly, what happens in these people, if there is a anterior skull base, you are asking how do they, you are discussing about the manifestation. Sometimes when the tumor or lesion is on the left side of the brain, they come with behavioral changes, loss of concentration, change in personality, and disinhibition of social events, and sometimes excessive sleepiness and excessive irritability, and passing urine without their knowledge, incontinence, what we call in the close. So these are the few complaints. If they go little behind, then when the pituitary gland gets involved with this, they come with hormonal manifestations. In a male, they develop hypothyroidism, that they start tolerating the cold less. They develop, you said, that bulky,
Obesity,
they start putting on weight. They develop what they call buffalo's hump, and they got moon-like face, round faces. And many of them, when they go for sexual hormonal changes, they lose sexual functions stress. And in females, again, same thing happens, that the few of them may develop excessive late onset milk secretion from the breast,
With non-pregnant milk secretion.
non-pregnant.
Correct.
They have suddenly they start secreting milk.
So we
We,
got,
we call it as
Gal-
amenorrhea galactoria
Correct.
syndrome. The menses stops
Correct.
and milk starts secreting
Correct.
from the breast for no reason. So these are all the manifestations of
And
the
some of them get embarrassed. They don't even reach out to doctor for some time.
absolutely.
They don't know whom to tell. Papa, we really blame them. We can't blame them at all, sir. That the young girls.
What you're telling is absolutely right. See, this happened about 3-4 years back. One lady, middle-aged lady from Karwar, she had this complaint, amenorrhea galactoria syndrome, going on for almost 1 year or 1.5 years. This is exactly what she said. Social, how can I tell that? ನನ್ಗೆ ಹೆಂಗೆ ಹೇಳಕ್ಕಾಕತ್ರಿ, ನನಗೆ ಹಾಲು ಬರಾಕತ್ತವ, ನನ್ನ ಮಕ್ಕಳೆಲ್ಲ ದೊಡ್ಡವರಾಗಿದ್ದಾರೆ, ನನಗೆ ಹೆಂಗೆ ಬೈ ಹೇಳಕ್ಕಾಕತ್ತಿ. You understood? So they keep them all day. Then she had a pituitary tumor. And next few people come with sudden spurt in the growth. Suddenly, the growth increases. The face becomes bigger. The fingers becomes bigger. The nose becomes bigger. The toes become bigger. The suddenly increase in the height. So this we medically call acromegaly or gigantism when they come. So these are the
Many of them have had ring sizes changed to sometimes 2 sizes.
Exactly.
Chappal size changing.
Exactly, that's
and
right.
They don't bangles. They're not able to put.
That's
inside.
right. Very true. Very true.
They have not realized that there's a problem, sir.
Very true. Very true.
Until they, I don't know.
True.
All we are trying to say, guys, neuroscience is not simple. It is not a simple chest pain, acidity. You go there, you get it. There's no one set of vanilla flavored symptoms that you get. It is so complicated, unfortunately. So I'll tell you one story of an anti-skull baser. He was, when I was a student training at Manipal Hospital, he was the brother of that then horticulture minister, sir. Okay, he's about mid-40s. For 2 years before he came to us, they saw personality change. Maner bandorgala bayadu, sir.
Okay.
Simply unprovoked scolding.
Right.
Then they started scolding family. It became so obnoxious. People started avoiding coming to his house. Family had no choice. They were just managing, this, that, without provoking him. And he just went on. They went on. Just went on. Then one day, for 2 months before they actually brought them to us, the son and wife observed that when he's walking in the house, he was bumping into objects, tripping, falling. And then they realized, ಕಣ್ ಕಾಣಿಸ್ದೇ ಇರ್ಬೋದಾ ಅಂತ ಒಂದು ಪ್ರಶ್ನೆ. So they were even afraid to ask him.
Exactly.
ಅವನು ಬೈದು ಬಿಡ್ತಾರ ಅನ್ಬಿಟ್ಟು. Then they realized there's something going on.
Right.
And then they eventually went to some doctor. They got a scan. He had a large olfactory groove meningioma, sir. And he came to us, sir. He got admitted to the hospital. I was still a resident at the time. I was the ward in charge doctor. I went to see him, 9th floor. He was smoking in the room, sir.
Okay.
Patient.
Okay.
So I said, how you can smoke in the room?
In the hospital.
He gave me abuse, baida sir. I didn't know what was going on. I just walked into the room. I was a student. I just said, how can you smoke? And I got fired royally.
This typical frontal lobe issue.
Exactly, sir. Exactly.
Lack of social inhibition.
Exactly.
Yeah.
Then after that, I realized all this story. I didn't know what his story was.
Right.
I just went in and then, okay, so everything happened. Olfactory groove. We operated him. Post-op, sir. Namaskara, doctor. Completely changed personality.
Right. Absolutely.
But you know the tragedy, sir? He was bilaterally blind.
Oh.
That vision never came back. Now you have a non-cancerous tumor, removed completely, no tumor recurrence. He's going to live for another 20 years, but blind.
No. This is exactly what happens. This is what you are stressing to the community, to the society,
Correct.
to the medical and non-medical fraternity.
Correct.
Recognition on time and treating on time makes a lot of difference. And it is a cure.
Absolutely, sir. It's literally a cure, sir.
Exactly.
With nothing else happening.
His behaviors disappear, problem disappeared, his life became all right, he became normal, but
no vision.
That
was such. I told you, sir. And that wife and son were beating themselves.
Right.
Sir, now karkomarಬೇಕಾಗಿತ್ತು, sir. ನಮಗೆ ಗೊತ್ತಾಗಲಿಲ್ಲ. They were so, we should have done that. And so they were taking the blame on themselves because,
but
again, but what to do? No, so you can't put one person, but we're only trying to communicate to understand that it's somebody has to observe that something is not okay.
Exactly.
And at least seek help, find out. It may not be a big problem, but good to know what's happening. Same way, sir, we had one more lady, one Goan lady. who lost her husband. Around the same time, she was observed depressed. So everybody thought husband lost, depression. Obviously went to psychiatrist, antidepressant. Not uncommon, not unfair at all. Like you said, 8 months later, she threw a fit, sir.
Okay, okay.
And then they realized she had a meningioma.
Meningioma, right. You can imagine that. That's right.
So we were taught in our training, any tumor that lifts the frontal lobe, lifts the memory. Anything that pushes the frontal lobe down depresses the not memory, the emotion.
Emotions.
So that's how.
Exactly.
So any
Right.
up and down of emotion withdrawn, some patient will be simply sitting like this. No, sir, no participation, no interaction.
True.
Literally like that's also an
True.
important thing for us
True.
to.
That's
observe.
what message what you would like to give to
Correct.
that is that the behavioral changes, the abnormal changes, which are not coming under control
Correct.
by medical management, by behavioral
Correct.
consultants, psychiatrists, it is always better to investigate them.
Correct.
One scan.
Correct.
One scan is enough. Even a CT scan is enough.
I agree.
If not a brain MRI, CT is enough.
So this visual field, I told you, I want to give an interesting story to
Yes, sir.
drive the point.
Yes.
There was one Kurgi guy, sir.
Right.
He was working Papua New Guinea, sir. Okay. During his childhood, Kurgis play a lot of hockey. Right. So one hockey incident, he had lost vision in one eye, sir. Right. So he was blind in one eye. He had only one eye. And Papua New Guinea, even for dental treatment, they had to come to Chennai, sir. It's very bad there.
That's right.
One day he felt he had some vision problem in the other eye. He couldn't figure it out. Anyway, I'm going to come. So he came to Bangalore, went to a local ophthalmologist, and they said everything is okay. So he was okay. Then he was sitting like this with a friend and having a beer, it seems. So a friend asked him, why you came to Bangalore? He said, no, I had some vision problem. So I went to ophthalmologist. He said, everything's okay.
So can I have beer?
No, I have beer.
You can celebrate.
He's like, but you know what? That friend simply, sir, see my finger. And then he started doing this, sir. That friend, not doctor, sir.
Not a doctor.
Simply he did. And when he did this, suddenly one patch, he couldn't see the finger, sir.
All right.
Then he made him do again. He could see finger, he could see. In the middle, he couldn't see, sir.
Oh, right. Scotoma. Okay.
Then he came to Manipal Hospital, sir.
Okay.
We did an MRI scan. Some near the pituitary gland area, there was some tumor-like situation was there. So we said we had to operate because you had a vision problem.
Right.
So we opened, sir, from top because it was suprasellar, it was on top, on top of the chiasm. And Dr. Asek was operating, and he is open, and we're not able to find anything, sir. We are searching here, searching the hill. What is this? Looking at scan, looking. Then suddenly we realized the entire chiasm, where the two optic nerves join the chiasm, was swollen, sir.
Right.
Bulging. He put a small incision on the chiasm, sir. You know what popped out, sir? One cystic circle. Cyst.
Okay.
One tapeworm larva came out. It was like...
it's a cure.
Exactly, sir. And vision is fine.
Important. Exactly. That's what I say. Very, very important.
So the simple finger...
Testing.
Which is why I'm saying, why don't the ophthalmologists do this very simply? And so I make it a point to make and sit in front of them and do this confrontation test we do for field testing.
Yes. Sharan, you're absolutely right. Whenever I send our patients to ophthalmological examination, who come neurologically, even though they have ophthalmological problem, I write 1, 2, 3.
Correct.
Kindly do visual acuity.
Correct.
Field examination and fundal examination.
Same here.
All three I write.
Same thing I write. Don't take
and
it
we
for
have
granted.
one of wonderful institute in Hubli, Dr. M. Joshi Eye Institute. Fantastic.
When they sensitize, they do this, sir. This is for me akin to the dentist not knowing about trigeminal neuralgia.
Correct.
How they pull out 1, 2, 2, 2. Average 3 to 4 teeth are pulled out by the time they show up in front of us.
Exactly.
It's the same way, guys. So,
this goes on. Yes.
Sir,
yes,
before we come to how you plan the surgery for this,
yes,
let us take a detour just to, people are already must be stressed. Oh, you did, yeah, they're looking at what's happening. So you are from Belgaum.
Yes, Sharan.
First of all, you tell me, did you want to be a doctor and a neurosurgeon, sir?
See, let me confess. I wanted to be a doctor.
Excellent.
That's for sure. You know why? Because in my family, we have my legacy. My uncle is a heart specialist doctor. He's the first doctor in our family who was trained in UK. He was an MRCP way back in 1960-70. Then he did a fellowship and everything. He is a consultant cardiologist in Canada and US. So he was our inspiration.
Oh, got it.
And my father's sister, she's a physician. And two of my sisters are cousin sisters are doctors.
Okay, so there was a history in the family.
There's a history in the family.
Got
So they were all our inspirations. I
Got it.
wanted to become a doctor.
Perfect.
Right. But see, my uncle, when he came back from US, and he's here in Bangalore here only. He's working here.
Oh, I see. Okay.
Then he wanted me to become a cardiac surgeon.
Okay.
He wanted to
Got
meet. He said, Suresh, you do a cardiac surgery. With that intention, I was working in Jaideva
To become a heart surgeon.
to the heart surgeon.
Got
I
it.
worked there for about few years. Then it so happened that the interview and this
Exams.
entrance were
Entrance exam.
taking long time. By then I was married. Then I had to look after myself. Then NIMHANS, the salary what was I was getting was very less to support my
I can
wife.
imagine.
Yes, I didn't want to take money from my father. Then NIMHANS entrance came. First thing I saw how much they are paying to the resident.
So you saw the salary more than the.
They
I
were
can
pay-
imagine, sir. I
Yes.
can imagine.
they were paying 2,500
Okay.
resident.
This is 19?
I tell you, 1980, 86, 85, 86, 87, 86, 87. Then I applied for that. Then wrote the exam. I passed.
See?
And got into with the thought that I'll come back and join Jaideva once they call for the interview and test. Then continued working there for some reasons. In Jaideva, it was not called for about a year, the entrance and test were in those days. I don't know the reason. So I continued there. After 1 year, continued. Then the entrance were called, but already I was 1.5 years in neurosurgery. Then I was slowly getting to like it and getting to things of it. By then we had a CT scan in NIMHANS. See, very important question you asked. Pre-CT and post-CT in those days made tremendous
sir.
difference
Tremendous.
in the outcome of the treatment
Agreed, sir.
of neuro problems.
Because what is inside, nobody knows. Sir.
Exactly.
So I still know, Dr. A. Segde used to tell us exploratory burr holes, carotid puncture in the neck,
angiograms,
looking at the vessel
shifts, and diagnose on those.
Huh?
A diagnose on those. Right.
So that was extradural, subdural, intraperitoneal, no idea. That
was a situation in those days. See, the pre-imaging of CT, the morbidity and the mortality in neuro was very high.
Huge. And that's some legacy is still continuing from there, and that thing in the older people, I think. So.
True. So it was quite depressing to do that. But just then, luckily for me, ultimately, Sharan, I think it's your destiny. What it decides. You want to become a cardiac surgeon, neurosurgeon, plastic surgeon. It's your destiny, what God has decided to you, and you become like that.
Perfect.
So CT scan came, and suddenly we saw in the sea of change in the management of these patients.
To today, you see that old CT scan was so terrible.
Terrible.
Yes. If you look at those images.
And it was only head scan.
Oh, I didn't know that.
Yeah. It's a CGR company from France. It used to do only head scans.
Oh, this I didn't know.
When the CT scan started in 1972 by Alfred Hounsfield, it was only the head scan, not the body scan. I think, if I'm right, I'm not very I think about 8 or 10 years later, or 7 or 8 years later, whole body was coils came out and whole body scans. So you're right, what you're telling. One head scan in NIMHANS in those days, I'm talking 1985, 86, 87, in those days, one head scan used to take 45 minutes.
My goodness, 5 seconds now. So 3 seconds now?
Today, yes.
3 seconds.
Yes. That's what I mentioned, advances in technology. It's a boon to us. But anyway, it doesn't matter. It was better than
something better than nothing.
Better than angiogram, better than ventriculogram, better than pneumoencephalography.
And quick, sir.
Quickly. So that's
no dye, no things.
Exactly. So the results started improving. The morbidity, mortality started coming down. Patients were getting better, much better. Then I decided to continue neurosurgery. And because I had a good friends in cardiac surgery at that time, who was with me, working there with us. So, because he was from Bangalore, he continued to continue in cardiac surgery, but he continued. Now he's in Houston, Texas.
Correct, you're telling your good friend.
Good friend. He's working as a cardiac surgeon. But my destiny probably it was this, and I became. But today, looking back, Sharon, I don't have any.
I think it was to be, sir. It was to be.
I don't
so.
have any regrets. When I feel God has given
I think it's much
things.
more challenging what you are doing right now.
Exactly. And what is happening all around the world, technology, developments, and things. If you have love for passion, neurosurgery is the field.
Yeah, I think so, sir.
I'm sure
I
agree.
I totally agree with you.
That's right.
I am also subscribed for the next 20 years. I have no plan to do. I want to be a neurosurgeon from 8th standard, sir.
Right. Okay. Okay. Much before that.
Yeah,
okay. Right.
I was very clear.
Very
sir.
nice, Sharon.
Because my mother used to subscribe to the Reader's Digest magazines.
Right.
So I was an avid reader.
Right.
And the first thing I would look at the Reader's Digest magazine is there's one section called Drama in Real Life.
You
remember that,
I
sir?
used to read those. Yes.
And the drama in real life was so vivid, no? So you could actually imagine the.
Very
and
true.
that one particular drama in real life was a lady who was skiing down the Swiss Alps.
Right.
And she fell unconscious.
Right.
And they picked her up in a helicopter.
Right.
In 1980s
I know.
helicopter. Oh, it was like,
it's a big thing. Very big thing.
Very big thing. You can't even imagine here.
True.
They took her to a hospital. They found an aneurysm in her brain.
Right.
They
Okay.
clipped it.
Right.
And then she became all right. They said, oh, this is some fancy stuff that's going on.
Right.
And that actually made me land the first helicopter in Manipal Hospital in the year 1998. Sir.
Okay.
So that was in my mind.
You followed the dream rather.
Yeah,
you followed the dream.
And airlift the first patient.
Right.
Next episode was a story of a Canadian neurosurgeon. I forget his name. Who was very good in brainstem gliomas. And with very good results.
Fred Epstein.
Yeah, Fred Epstein. Fred Epstein.
Yep.
And he also spoke about how to handle the parents and the grandparents. The grandparents come in, the emotion is as intense as the surgery itself and things like that.
Very true. So managing the family.
So that gave me this dimension that I had not realized when I was looking at this.
Right.
And then the third one is about the brain itself. One more episode where nothing is known, very little is known about the brain. So much is being explored. And I love exploring as a kid, sir.
That's right.
So I said neurosurgery. That's all it is. I chased my dream.
I congratulate you.
Thank you, sir. Thank you.
And again, see the amount of work and with the passion, what you are doing it to it's a passion.
Agreed,
nothing
sir.
else.
Agreed.
You have to be. See, that's what Professor Das, he used to tell us. If you're a neurosurgeon, you're mad and you're passionate.
I mean, I can imagine him telling you this.
Exactly.
I can imagine him telling this.
Only mad people and passionate people take neurosurgery. In those days, he used to tell us. I mean, as a lighter.
Absolutely, sir.
Lighter note.
He's a great man, sir.
Yes.
I didn't. I mean, I had met him. I didn't train in demands,
yes.
But he was my examiner in my final DNB, sir.
Wonderful person.
And he said when we went to Vivano, sir,
yes.
He had a set of myelogram images, sir.
Right.
You fellows, you only see MRI. Let me see what tuck. Luckily, I had studied about myelograms, sir.
True.
Both cervical and lumbar.
True.
And I said everything. He said, oh, you have studied. Very good. I'm happy. And he was very happy, sir.
Very.
35 images he had, sir.
Oh, I know.
Tuck. He's putting, sir.
Wonderful person. Yeah. Wonderful person. So he used to tell us when he was our professor. In those days, things had improved to such. He used to tell us in our days when I was trained in All India Institute for Neurosurgical Training, when the patient comes to the surgery, patient head is shaved. But the tradition was you want to shave the patient's son's head also.
Really?
Yeah. He used to joke with us. Those were the situations in those days because nothing was certain. Because diagnostics were like that and everything. But today you see where it's, as we discussed in the earlier part, 60%, 70%, 80% we can give that.
I agree with you. Some of them are very challenging. I mean, I've seen some of the surgery videos you have put up, very challenging things. I agree with you.
So everything, as you rightly said, Sharan, it has a legacy.
Correct.
Starts with a low, keeps going, growing.
But that persistence somebody has done so that we could walk a better path than them.
Exactly. You walk on the shoulders of the great teachers.
Well said.
Always see today what I am, what you are, what all of us is all because of our teachers.
Exactly. No questions.
Today, see today, well, in the modern era, you are using a high technology, high technical instrument, technical things, and all those things. That's fine because the things have changed and you are getting easily to them. But they put you on the right track. They taught you the basics of humanity, basics of life, basics of neurosurgery. You may be doing well today, but the credit goes to
Yes, sir. No question.
our
No
teachers.
question. In fact,
Always I feel that till today.
My guru in Japan, Professor Taira, always says, "A fool with a tool is still a fool."
Fool.
So don't overestimate the tool. The tool can only do as much as you know how to use
Exactly.
it. So go and learn it correctly is what he would say.
That's right. Very true.
And I know you had 3 gurus who honed you apart from all the people who taught you in NIMHANS.
Yes.
He's Professor Dr. Sen Gupta, Dr. Yasser Gill, and maybe this is the right time since you raised the issue of guru.
Yes.
What's your thing with Dr. Sen Gupta? How did that connection happen, sir?
See, after I finished in NIMHANS neurosurgery, I was for the fellowship. I went to Newcastle. He was.
He's from Newcastle. Correct.
He was in Newcastle. He's a very senior.
Correct. Dr. Robin Sen Gupta.
Is Robin Sen Gupta.
Correct.
He was. At that time, he was quite a senior neurosurgeon, not only in Europe, UK. He was in Europe also.
Correct.
Almost he has spent about 35, 40 years. A very, very nice, wonderful person. Very wonderful person. Highly committed with a passion to neurosurgery. True. And again, what happened is all people, younger generation, coming from India or any for that matter Asia, he used to support them. And believe me, he used to see weekend. He used to take us to his house for food.
So because you're missing home.
Missing home, yes, yes. And Mrs. Sen Gupta used to teach our wives how to cook Bengali food.
Very nice, sir. Very
you understood.
So
it was wonderful working with him, and at that time came across a lot of British neurosurgeons, and there every month end we used to have Anglo-French, Anglo-German, Anglo-Italian meetings, conferences, where they used to get all the experience from the European territories. And there, for the first time, I felt going through those meetings and listening to their presentations and other things, the documentation in whatever subject you do is of utmost importance.
I think that is what we are still weak on, and I think very well said, sir.
Yes. Documentation. Today, you don't talk. Show. See, if I go and tell that I have done 20,000 brain operations, I have done 2,000 aneurysm surgeries.
Nobody believes.
Nobody believes. You show the work. You show what you have done and how you have done. That's exactly what I learned from there in the Sen Gupta sir and documenting. He had already written 10 books by then.
Yeah, I know, sir. Some of the books, sir, I can't say I've read all of them, but few I read was very good, sir.
Till today. Then when he again what happened is, he wanted our Indian boys to stay back and continue there. Then he offered registration to Newcastle University for FRCS. Again, I had to go through the thing. Somehow my wife was not very, comfortable staying there. She said, no, we'll go back to India. That's how.
I think the country needed you. So I think Bharat Mata has pulled you back.
Destiny.
I agree, sir. I agree.
But today I don't have any regrets for not staying back in UK, number one. There what happened when I was coming back. See, this is what the magnanimity of a great person. Professor Sen Gupta. He said, look, you have seen us. Now you're going back to India. I want you to see few more people. In those days, there was no cell phone.
Oh, like him.
Like him. No cell phone.
Correct.
No
internet.
No internet. Nothing. Then he wrote a letter, a telephonic thing from Newcastle to Professor Yasser Gill to Zurich. He said, one of my Switzerland, my student from my country, he wants to come and stay with you for some time. Believe me, Sharan, in those days, I'm talking 1990s, first of 94, 95, to get a thing with Professor Yasser Gill used to be 2 years, 3 years, 4 years waiting list. Within 15 days, he gave me a thing for 3
Wow.
months. Free accommodation.
Really?
Yeah. Free accommodation. Only I have to look after my food and other things. Again, food in the hospital quarters. Practically, very well, francs, very less it was. And our requirement was very less. That's how got exposed to Professor Yasser.
Yeah. I mean, he's a
Then
legend as far as CPI
I,
angle
it
goes.
was, it changes your
Perspective. I agree, sir. I agree.
perspectives. Then
I think I recommend all neurosurgeons go abroad for some strength. I think it made a big difference for me also.
yes, learn
Yeah.
and come back. Because
Come back, learn and come back.
Come back and work in your own country, work for your own people.
Yes.
That's what I that
Thank you for this
that
message.
that
Excellent.
thing. Because see, everything is here. And I tell you, Sharan, today, believe me, what is happening all over the world, the social structures, medical social structure, you go to America, you go to Europe, you go to Germany, you're always a foreigner. You're not a local. They look at you in a different way.
And also your skin, sir.
Yes, exactly. That's exactly what happened to us.
You also experienced
Yes,
that,
yes,
sir?
I experienced that. But it's a part of life.
I think so.
You cannot.
Every human being does that. You only have to accept it's not just in India. It works all over the world.
You have to understand that. Because that's nothing but natural. They have their own way of doing it, and you're a minority. You accept it, and you want to go stay back. Otherwise, you just leave the things and come back and do. But today, the best place to work in this, I felt, my personal opinion, is India.
I agree with you, sir. I second you 100%.
Yes,
I tell everybody today, if ever there was a time to be in India, it is now, sir.
exactly. You're right.
It is now.
Now and future.
Correct. That's what.
Now and
yes.
And
Next
future.
20, 30, 40 years, I think all of us can build the nation that we want.
Exactly.
And I think can be proud of it. Sir.
Right. Today, everything is available.
Yes,
here.
yes.
So, younger generation are really good coming out today with lot of newer advanced technological knowledge applications. They're coming up and social media and the internet availability of the information is very good to them. Use that. Go out. Stay for few years, 1 year, 6 months, 2 years. Do something different. Learn something different. But come back.
Get that perspective and come back.
You can do better here.
Agreed.
Better here. And you can do much better work here. And again, most importantly, Sharan, your people need you.
Correct. Exactly, sir.
You belong to this place.
Yes.
You got it.
Yes.
Exactly.
And the social support is very different here.
Very
sir.
different.
Very different.
True.
Very well said, sir. I think
Yes.
you gave a very nice flavor to that.
Then apart from that, again, he referred me to Professor Sami.
Oh, the two legends.
Two legends in Hanover.
Hanover in Germany.
Yes. So
that
I could.
Is another
yes.
amazing. Both these guys are incredible.
So I owe him a lot, Professor. Till today, every year I meet Professor Sengupta at Kolkata.
That's what I was saying. He comes there, no? INK.
He has established International Neurosciences Center.
It's INK, no, sir?
INK.
I know. INK was his baby. I
yes.
know that. Yes.
He
comes there. Okay.
He is there. He manages that. He runs the whole thing. We have a lot of neurosurgeons. Wonderful center. It's like a mini Nimans.
Correct.
I heard recently that he wants to start a university also, medical university in Kolkata.
So now, sir told about UK. He went here, he went there, and he's saying this is the time to be in India. Now we'll ask him the key question. Sir, when you left Nimhans, Bangalore, and went to Hubballi, you have to tell that story. So how did you land up there? And what was that whole journey you had in the first few months? Please tell our audience. So to know, Dr. Dugani didn't walk into a beautiful place. He didn't just roll up his sleeve. Somebody didn't put a red carpet and welcomed him. None of those things. Don't look at his demeanor now and think that he was successful from the beginning. This man has you cannot imagine what he has done to get to where he is. Sir, please.
Thank you, Sharan. It's a journey. It's a life journey.
Absolutely.
As you rightly said, it was not a simple life journey when it started with going back in 1991. Going back at that time. After I enhanced, we started myself, Professor Hegde, along with A.S. Hegde sir,
He was
Venkatramana.
my teacher, sir.
Exactly.
All of them my teachers.
One of the wonderful human
Yes,
beings.
no question. He
Wonderful
loved you,
teacher.
sir.
He loved.
He loves you. He loves you.
I till today.
Yes, yes, I
You
know,
understand?
He loves you.
He is our God and he is our mentor. One of the wonderful microsurgeon ever you get in your life. Human being. Wonderful human being. That's what I told you in the beginning. You don't learn neurosurgery. You learn the values of life with from your teachers. And along with neurosurgery, values of life.
Yes, yes. Very true.
They help you to
I think that
go
is
up in
more
life.
grounding than the skill, because skill is forever, sir. You'll keep on improving. But that fundamental being a good human being and wrapping that, I think, is key.
Exactly.
To
That's what
success.
it is. Our teachers
Yes,
had.
well said.
So then we worked for some time in Manipal Hospital way back in 1991.
You were in Manipal then,
Yes,
huh?
yes.
Oh, I didn't know
Professor
that.
A.S. Hegde, Venkatramana, myself and Dilip Panikkar.
I know. When I joined in August 93, I think you had left by then.
I had left.
I didn't know
Then
that
what
you were
happened?
there.
Yes. I worked few
I
years.
see.
We are the 4 people
I
who
can't imagine that you were there. I didn't know about
Yes.
this. I see.
Then what happened is Professor Das asked me. In KMC Hubli, Karnataka government had asked him to start the Department of Neurosurgery in KMC Hubli. So anybody, a young neurosurgeon, want to go to Hubli, start the department.
I think at that time, entire North Karnataka had no neurosurgery. I think,
There was a senior neurosurgeon in Belgaum.
Only Belgaum.
Belgaum.
JNMC.
Dr. Mahant Shetty
Correct,
was
Mahant
there.
Shetty.
And in Hubli, there was a neurosurgeon, but not trained neurosurgeon, general surgeon with that. Then Professor Das called me and told me, Suresh, it's like this. Do you want to go to Hubli because you're from that side and start the Department of Neurosurgery? I felt, basically initially after working and training in NIMHANS, you're always an academically. Then anybody gives starting the department in a teaching hospital, postgraduate teaching hospital, it's an opportunity, God-given opportunity. I said, yes, sir, I would love to go there. Then he talked to the health secretary and the health minister at that time in government of Karnataka. Then they said you can apply and we'll process it and you can join. Then they said in the meantime, you have to resign from the NIMHANS. I was an ad hoc pool officer, senior registrar in NIMHANS at that time. I resigned. Then went to Belgaum, my native place. Then because secretariat at here, they told me you will get an appointment letter soon. Then I said I will take a break for about a week or 10 days and went back to my native place, waiting. It never occurred.
Really?
Yes.
How many weeks or months you waited?
I waited for about 2 weeks. Because as a neurosurgeon, you can't sit.
You get restless. I agree.
Then by then I came back to inquire it in KMC. Have they received any letter in those days? Because nothing, a phone call, nothing was there. More of either
physical
landline or physical. When I came back to Hubli to inquire whether you have received my information letter from government of health ministry, Karnataka, they said nothing, we're not. In the meantime, I thought we'll meet local doctors. Just because just then CT scan was installed in Hubli, 1991, at NMR Scan Center.
Okay, NMR, correct, NMR.
NMR Scan Center. Then because I was hopeful that I'll get a appointment letter, KMC, and so that I can meet local people and tell that neurosurgeon, I'm a neurosurgeon joining here, working here. Somebody suggested we meet senior doctors in that area. So I went to meet senior doctors just to say hello. As a respect, sir, I'm so and so and a junior person. Then I was staying in a hotel. I had met in the daytime one hospital doctor, his name Dr. M.S. Bembalgi, Shivakripa Hospital. He was a senior anesthetist, trained in KEM Mumbai. So he had started a hospital with a good infrastructure with intensive care and other things. I had met him in the afternoon and came back. I was staying in the hotel and coming back to Bangalore next day. Just then, a ward boy came running to the hotel.
Looking for you.
Looking for me. Okay. He came with one letter from Dr. Bembalgi. The sir, there's one patient is there. This boy was hit on the head in the 2 days back, 1 day back, and he had a fracture of the hand and head on the head. He was admitted in the hospital for treatment of this and this. He was quite all right in the morning. Sir, now he's not talking.
Oh, okay.
Please,
Typical story.
Can you come and have a look at the patient? Then when he has called me, I cannot say no. I went there and saw the fellow. He's young fellow of about 21, 22, and fracture of the forearm and cut of the forehead on the right side. Assault with the axe and something like that. Then I saw him. I asked a question. Morning, he was talking. He has taken orally, and he was responding well. But when I saw him, it was 4 o'clock in the afternoon. They called me to see. I saw him. His glaucoma score is drastically gone. He was even, no eye opening, no speaking, and he had hemiparesis on the left side weakness. I saw his pupil has increased, blown out in size. Then I told sir, there is a blood clot in the brain. Looks like that. The person who had we call it a lucid interval, and he needs immediate scanning.
Correct.
They had not done a scan also because he was quite all right. Then he started getting scared because a police case, assault case.
Correct.
And fellow was conscious talking. Now he's not talking. Then they called the ambulance, put him in the ambulance and took him for scan. And me and him, we went along with the patient on the scan. Then scan was done in next 45 minutes or 1 hour. It's a huge extradural hematoma. EDH on the right side. Big one with a midline shift. Then I said, where I am stuck now. Because I told sir, there is a blood clot which he has developed because of the hit. And if you don't operate in next maybe 2-3 hours, this boy may die.
Correct. He'll die.
He may die because of one people dilated.
Correct.
Then he started getting scared because it's a medical legal case, and between some political person had assaulted him. Adbere. This fellow was running a dhaba, Punjabi boy. And they had assaulted him on some quarrel, something. They fought with each other. Then he said, do something, sir, do something. Sir. He cannot be shifted anywhere because next shifting is only to Bangalore. It takes 6-10 hours in those days. By then, do something. So I said, sir, it needs to be opened up, but how can I do it?
Correct.
Then he told me, Suresh, that there is one women's hospital which was run by Britishers in earlier days, in those days. And this person, when he was junior, he used to work in that hospital. Bembalgi. He said, I have seen there some British surgeons opening the skull during the surgeries on the skull at that time. There are some instruments. You just please will go and check them back.
So you went there?
We went to the
hospital. Amazing.
Yeah. Then we saw that there's a Hudson's brace, which was rusted.
Okay.
It could not be moved.
So you put oil and all that.
Oil. Sir, I said this will not work. Yenre matri. Because it's his responsibility. Something goes wrong, you have to answer. Young fellow. Then we took that, put it in the oil. There is no cautery. No cautery machine.
Today our brain will not work without cautery.
Without bipolar. No bipolar. No monopolar cautery.
Sure,
then orthopedic surgeon hospital there, his friend, he big cautery machine. We shifted the cautery machine to the hospital and nothing else was there. No cranial saw in those days. Nothing was there. Only the one Hudson's brace. One burr hole was to be made. Then I said, sir, we'll try to do something, but tell the family outcome is not very good. We'll try our best to do this in this case. Then we took him up by about 7 o'clock or so for surgery and made one burr hole and nibbled a hole about 1 inch
My
square
goodness, sir,
skull.
I can imagine how it is. It is.
Then.
But nibbler was there.
Nibbler was the bone. Orthopedic spine nibbler was there. That time I still remember Dr. Das used to tell us, your neurosurgical training should be such a training. you should be able to operate the patient on the trolley. If you are asked, you should be ready to do it on the trolley also.
Amazing.
That
What
it
a
started
vision.
ringing in my
Correct.
my head.
Ah.
Then nibbled and took off the blood clot and closed. And next day morning, this fellow became conscious and talking.
Amazing.
It was like a miracle to the
Miracle. Of
everybody.
course, sir, it's a miracle.
Miracle.
Of course.
to them. Then what happened is, since I am here,
Uh.
I have operated. It's a post-operative hematoma evacuation.
Correct.
I cannot leave the patient and go immediately.
Correct.
Because there can be reaccumulation, there can be so
Agreed.
many things.
Especially when you're done in a compromised situation. Correct.
Then I said, I'll stay back another 1 day, sir. Then once he's stable, we'll repeat a scan. Then I'll go back. 1 day over, repeated this.
Sir is so honest, and he says his commitment is not just to cut, commitment is to make sure patient is okay. This is very important skill you get as a surgeon, any doctor. You have to make sure, you hold the hand till the last. Thank you, sir, for giving that message.
Thank you, sir. Thank you. Then repeated the scan. It was quite all right. Then I was about to leave. Just one more call came.
Match fixing was going on
exactly.
to pick Dr. Dugani to
Yeah, Hubli. Exactly. There's a destination. Yes. One more, same, see what happened is, when I was in NIMHANS, along with A.S. Hegde sir, we had operated on clival chordoma. And again is a big politician in those days from nearby Hubli city, and then just outside Hubli city. He had a clival chordoma. We had operated at
it's a brain tumor here.
Brain tumor, yes. Then he was subjected for radiation and other things. He was in the house. Suddenly what happened, within about 3-4 days, he deteriorated and became unconscious.
There in Hubli.
In Hubli, nearby Hubli, and village is there. He became unconscious and he was lying in the bed. Then suddenly the patient's son is a politician. Somebody told him there is a NIMHANS doctor who has come and he operated yesterday on brain. So why don't you meet him? Then he didn't know who is the doctor. When he came down to the hospital where I had operated there, and when I saw him, I recognized him.
Oh, what a
He recognized me because we had operated on his father. Then he, sir, hingri ನೀವು ಮತ್ತೆ ಹೆಗಡೆ ಸರ್ ಮಾಡಿದ್ರಿ ಅಲ್ಲಿ ಹಿಂಗಾಗೈತ್ರಿ ಬರ್ರಿ ನಮ್ಮ ಫಾದರ್ಗೆ unconscious ಆಗ್ಯಾರತ್ತು. Then I couldn't say no because of the social. Then he took us in the car about maybe 15-20 kilometers from Hubli city. Then when I went inside the house, the patient was kept in the center. All ladies and family people sitting around him and crying.
Ayyo. They thought
he's dead. He's dead. Then I looked at the person who tirkondaralri mattak nan karisidri in Kannada. He's no more than why did you get it? No sir, when I came out about an hour back, his chest was moving, he was breathing, and please do sir. Then when I saw his pulse, he had a pulse. You got it. So breathing was shallow, but he had a pulse. Then I just gave a little sternal pressure. He pulled his legs. To his family people, it was a miracle because they thought he's dead.
Correct.
Right? Then his wife, elderly lady, she fell on my feet. Sir, do something. Please do something. Nodri sir, ನೀವು ಕೈ ಹೆಚ್ಚಿರಿ movement ಮಾಡಕತ್ತರು ಏನರೇ ಮಾಡ್ರಿ ಅಂತ. In Kannada, do something. Then I said, you have to have a scan for him immediately. That time, there's no ambulance. To get time for ambulance also. So we lifted him in the bed sheet, put him in the jeep. Behind the jeep, in those days, police jeeps. We put him behind the jeep. Sure. I sat on the sofa, jeep behind, and we brought him to scan center.
Amazing.
In the scan center, NMR scanner, we had IV lines and other things. I gave him steroid, Dexona, then put him on IV line. BP was 90 when we checked, because I hadn't checked the BP also because nothing was available. Then BP was 80 or 90. Put him on IV line, put the steroids, and got a scan done immediately. Sitting there, when you saw this huge hydrocephalus.
Water collection in the brain.
Water collection in the brain because of the tumor recurrence. Then I said, look, Hingaitri, his name was Katigi. Hingaitri sir, matta you have to put a shunt from the brain to
We
the
put an overflow pipe from the
Pipe.
head into the abdomen.
abdomen cavity to save a life of this person. Then I don't have any facilities, but he's not in a position to
Go to bank.
go
Same
to
story.
Same story.
Previous day story, same story.
Same story. Again, same story. Then again, same work. What we worked in Nimhans.
How can you do a shunt outside?
Outside,
Uh.
without a shunt tube.
Without shunt tube, correct.
Without a shunt, there's no shunt tube.
Correct.
Nobody was doing those things. Then, in few cases in Nimhans, in those days, when the shunt tube supply was not there, we used to put a infant feeding tubes.
Correct.
I've
seen that, sir.
Yes. That helped us.
Ordinary tube, feeding tube for babies we used to give to put into stomach. They used to put that inside.
Inside the brain. Then that's what it's all. So I'll do it, but guarantee outcome we cannot assure you. That's the only way left to do it. If you are agreeing for whatever outcome, we'll do it. They said, do whatever you want, sir. Do it. Then shifted him to the hospital there. Same hospital where I had worked. There was a rusted bias. I did a burhole. The tunneler you need.
Correct.
Put the tube
to put the tunnel.
from stomach to the. There is no tunneler. And there is a very senior vascular and general surgeon who was extremely efficient and extremely what you call skilled surgeon, like my godfather, Dr. Maling Shetty, Prakash Maling Shetty. He was American trained, and he was in American working both in America and India. So luckily he was there that time working in the same hospital, vascular surgeon, general surgeon with a vascular surgeon. Then he said, Suresh, come, I'll help you to do this. Then, I put a burhole, and from abdomen to here, we used intestinal clamping.
The long one.
Long clamps, intestinal clamps to tunnel from here to the brain.
See the innovations.
Exactly. This is what we have to do.
Jugaad.
Yes, Jugaad. It's a necessity.
Correct. Necessity is invention.
Exactly. That's it. Then tunneled, made one incision here, put that, and passed infant feeding tube and put a shunt and leave it in the.
Now such sophisticated shunt tubes, he's put an ordinary tube,
which was used for a different purpose.
Different purpose. Not in for shunt. Correct.
So then finished. I was tired. I went to the hotel. I came back and saw him at about 11 o'clock in the night. He was opening his eyes. Next day morning, about 9 o'clock, when I went to the hospital, he was eating breakfast.
Amazing. Somebody who was declared dead.
Yes.
12 hours ago.
Exactly. So it was again a miracle for the whole family.
It is amazing.
Then what happened is, they asked me the question why I went to Hubli. I have operated this fellow.
No,
I operated another fellow. How can I go back another 1 or 2 days? I have to see post-operative. We have to make sure they are.
Once you touch him, he's your baby.
Exactly.
Yeah.
You make sure that he's because no complication, because there's no backup to look after. I stayed back for 2 days, one after the other. People started coming.
And you're staying in hotel?
I was staying in a hotel. Then what happened is, I realized so much of work is here. Because without any facilities, without any system, if we can operate one complex brain operation every day, you can imagine if you stay back, how much you can do.
Correct.
So I continued to stay till these people get over. Every day, Sharan, I started operating.
Amazing.
Every day. Something or the other.
Amazing. And
believe me, after 6 months, then I took an apartment and stayed in the place. After 6 months, Professor Das called me up. Suresh, what happened? You were supposed to come here and join. What happened? Are you happy there? Sir, I'm doing well. I'm operating. Things are better. What happened to government job at KMC?
I've forgotten about that.
It has not yet come, sir. Then again, you go and talk to the government people if they want. If you're happy, you stay back. Otherwise, you come back and join Nimhads. Already Nimhads or Manipal, wherever. You are always welcome here. Then went on. went on, operating patients, work. I never thought back again to coming back to Nimhans or Manipal Hospital, Bangalore. And life continued there. Sharon, till today, every day
Every day.
we operate.
Sure. Amazing, sir.
Now
amazing.
that number of everyday surgeries, average falls between 4 to 7
My goodness.
every
day.
Every day. 3 to 7 every day.
Amazing low workload.
System, we built up the system. Then we got a MRI in 1997. We installed open magnet MRI. Then we installed 128 slice 3D CT scan. Then microscope. I came back went to UK first, I told you, came back, again continued to work there. Kept on adding newer and newer things. One thing I would like to mention to the younger generation is that any medical branch, we have to keep up ourselves with the technology.
Whatever the latest is happening, sir. Yes.
We must
upgrade
it.
So what is saying medical technology? People will not buy Nokia 1100 phone now, sir.
Yes.
Everybody wants latest phone.
Exactly.
You and me maybe have a little older phone. Everybody.
True.
So
Yes.
if they want to upgrade their phone, they might as well upgrade what is more important than a phone, no, sir.
Life saving.
Exactly.
Life saving.
I agree with you.
Yes. So that's what we kept on doing. Then improved the microscope standards, GIS microscope. Then by 2004, we started using the endoscope. Because see what happened in those days in Nimhans, we were not trained in endoscopic.
Correct.
It was not, still had come to it. Then I went to Singapore, where
I saw some of your videos. You're using the endoscope.
yes,
Yes,
Kasami.
I saw that. Yes, I saw
Kasami.
that. Yeah.
He conduct 2 weeks program in Singapore for endoscopic hands-on fellowship training. So I picked up endoscopic from 2004 and we started using endoscope. Then we kept on increasing the work and increasing the technologies. We got a QSA in
These are all
2000.
new instruments. Just to pause. Endoscope is not the endoscope they put it to see your stomach. We have a neuro endoscope that you put inside the brain to see corners at sometimes which you don't see with the regular microscope.
Through the nose and through that we started using it. And QSA, where to break the tumor, brain tumor. And
Oh, that QSA is such an amazing instrument.
Very true, sir.
Yesterday also we were commenting,
Yes.
sir, if QSA was not there, we would have struggled to remove this tumor. Just yesterday also.
Exactly, that's right. So we added that. Then suddenly, Sharan, what happened is your students that I told you, craniofacial department, we started in. We used to train our students in neurosurgery and skull-based surgery. In those days, you asked about the documentation and the recording. Every surgery, we used to take a record, photograph.
Okay.
In
Really?
those days, there are no videos. What happened is we have a camera like this, and we had what is called as a ring flash. You don't, we know in those days. Ring flash means the flash is a round ring attached to the head of the lens. So that was the technology used to take intraoperative photographs. Where you see in those, you've seen Roten, you've seen Sami, you've seen Professor Shekhar sir, all seen like Fukushima, Schwartz. All these people in those days, the scan photos were there. There are no videos.
Correct.
Those photos were taken, intraoperative photos were taken with ring flash.
Oh, I didn't know this. I see.
Yeah. Then we started taking the photographs. Then we started producing them, showing them in the meeting. And just then, by I think 2007 or 2006, YouTube had started.
Okay.
YouTube was initiated for the first time. Then by the same time, our operating microscope, which we had a camera, we changed it to, for the first time, we got inbuilt video camera. And we started recording the videos in 2006, 7, 8 at that time. Then our postgraduates started telling me, sir, everywhere we have photographs in the literature. Every book is there, only photographs are there. Now only the papers are available. Academically, reading the papers are available. But nowhere, sir, we have seen the operating videos so far, how to do the operation. Sir, why can't we put these videos on the internet?
What a futuristic.
It was the students who,
amazing.
postgraduates, our postgraduates,
Amazing.
they just gave me an idea. Then I said, look, this editing takes 4 hours operation.
Correct.
6 hours operation. You have to, nobody will sit and watch your operation for 6 hours.
Correct.
And there's no space on YouTube in those days for 4 hours. No, sir, we have a material software available, sir. And they're all tech people, young, craniofacial postgraduates. We'll edit it, sir. We'll make it 5 minutes.
Oh, okay.
We'll make it 10 minutes. Then I said, you do it. Let us see. Then I gave them a video. Within 1 week, 4 hours video, they made it 12 minutes.
Amazing.
Okay. Then when I saw the video, well, it was made. But the points...
the steps of surgery they would not have missed because they didn't realize.
Exactly.
I get that.
They missed. Then what happened is, every weekend, Saturday, Sunday, I would sit with both of them and edit the videos.
You tell what is important. Got it.
In that process of learning, I learned from them, from students. I learned the art of editing. This is how the life goes on, Sharan.
And such a beautiful YouTube channel you have, sir.
Yes. So then they started uploading on the YouTube. Then I asked them a question. Look, we are sharing the data, private data of the patient, and we are sharing the patient's photographs and videos. Then we consult. It is not ethically correct because unless then we contacted the lawyers. In those days, again, you see how you learn the things. There are what are called as media lawyers.
Oh, really?
Yeah. There are separate media rules. That's what happens in YouTube if you put it. There are separate set of media rules where you need to follow them. And for that, the set of permissions are there.
Now I know, but I didn't know they were there at that time.
Modifying and they keep changing. So we went on through the lawyers and they formulated them and everything was explained to the patient. This is what it is.
Like a consent.
Consent to it. This is why you are doing it, what we are doing it. So whoever consented, we started using that. Ultimately, see again what happened is many people keep telling me, many people keep commenting on why do you put patients' videos at the end of the surgery? Why you want to put the patients' videos? Then I said, if you don't put the patient's videos, there is no meaning to your surgery.
Correct. Your dialogue in English was operation successful, patient died.
Exactly.
You don't know what the outcome was.
Outcome is important. You have done a fantastic, sir, but how it benefited the patient, that you need to show.
Only then we'll believe, sir.
Then only they believe you.
Yes. Agreed.
For that, you need a complete, legalized factors are taken care of. And that's how it went on. Till today, we practice the whole thing. And after we started, Sharan, in those days, no American, probably, I think Seattle University and another 2-3 Stanford University and Ohio University, Mayo Clinic, they had this video channel. After we started, many
followed you.
Started doing it. We started in 2009. 2008, 2009. They all started 2010, 11, 12, all the things. I think at that time, Roten's channel was there. Albert Roten's channel was there. So that's how, and again, the next important thing which I'd like to clear to the younger generation is that when you upload the videos on YouTube, if your viewership goes above 1 million or whatever, then YouTube, there is something called monetization, where they give you they share the advertisement money with you for your channel viewership. So YouTube asked me that you will monetize channel. I said, no, I'm not monetizing my channel because, see, for the sake of education, we are using the data of the patient. It is unethical to take money for somebody else's data. Till today, not a single pie we take from the media houses for propagating.
Excellent.
This is
Excellent.
what
Thank
it
you for
is.
sharing. I didn't know this. Thank you for
Yes,
sharing.
thank you, Sharat. This is
So,
what it is. Yes,
excellent.
actually.
Now that you have spoken so beautifully about documentation, the surgery, the outcome.
Yeah.
So we'll go back to where we had paused.
Yes.
So tell me now that this patient has come, the scans have been done, the diagnosis is done, you know this guy has to be operated, whether it's the anterocranial fossa, middle cranial fossa, posterior cranial fossa. We will not take specific for that right now. Generally, sir, normally we say, for the sake of the normal audience, we say we have three parts of any surgery. We have the pre-operative preparation, the during the surgery process, and post-surgery what we do, because eventually this whole journey is going to determine the outcome of a patient,
Very true.
good, bad, or worst outcome.
Very true.
So you just can't, without any preparation, like going to a match without preparation, you just can't go into a match and expect to win the match. It's much, much more complicated here.
You are
So
right.
tell me, sir, each of us have different ways of processing information. So can you tell our audience with all that, and especially the doctors, how do you prepare for a surgery, especially a complicated surgery?
Yes.
What
Sharat.
does Dr. Dugani do? Give us Dr. Dugani's formula so that we can learn from some of that.
Thank you, Sharan. Thank you. It is nothing very different from what you do or what we do. It's all same. One most important for the younger generation or our medical things is study the image very
Well
carefully.
said. Well said, sir.
Very carefully.
I agree.
Before surgery, either a CT scan or a MRI scan or an angiography or whatever document you have with the patient, minimum you see for 8 to 10 times. You see it again and again and again and again. Put that picture in your head.
It's like loading into a navigation system.
Exactly.
I agree. Don't you agree, sir?
100%.
Yes.
You're right. Keeping it in your head.
Correct.
So, because every time you see the image, you get a new
Correct.
detail,
Detail.
new information, especially angiograms.
Agreed.
When you see them, you new things you get. And whenever you see,
every minute detail is critical, sir.
very true. You have to study it. Just because I saw the, chalo, take them up. A wrong, very wrong way of doing. Study, see, again. Minimum 5 times.
Well said. Well said.
Fix the picture in your head. One night before, you imagine how are you going to conduct the thing. And with your assistant, our anesthetist, one night before, I talk to them. Strategy. What I require in this patient. Because for an anesthetist, every head surgery is the same.
Correct. I agree.
Right? But for me, it's an aneurysm.
Yes.
For me, it's an AVM. For me, it's a glioma. For me, it's a skull-based tumor. For me, it's a vascular tumor. So for them, it's the same. For us, it is different. So what I require tomorrow morning for this patient, same day evening, we sit and talk to them. What are you going to do? What is anesthesia-wise we require? What do we need to control in the anesthesia? Blood pressure monitoring control and bleeding monitoring control and hemostatic agents, position of the head of the patient, all this, and lumbar drainage thing, and induction level blood pressure. Because
at the time of giving the
anesthesia, when you give the anesthesia, suddenly patient BP shoots up, he will have catastrophe. So this is extremely important for a younger generation to understand once we do this.
So about the imaging, I want to say what I tell my juniors.
Yes.
I always tell them all the images we get are 2-dimensional.
Yes.
We have to take the 2-dimensional image and make it 3-dimensional in our head, sir.
Absolutely.
That is the first and most important thing the students have to learn, sir.
Exactly.
Secondly, you are seeing the image like this, but you are seeing the patient in the image like this.
Exactly.
So you sometimes actually rotate it around to see what happens if this turns, sir.
Very true.
So that you get from the position of you where you are going to approach the tumor, what am I going to hit first?
You are absolutely right. This is where I 100% agree with you. You know why? All these images are taken in a different position.
Correct.
When the patient lies on the anatomical position on the table,
Correct.
the image becomes
Yes.
upside, especially angiogram.
Yes. Exactly, sir. Yes.
Angiogram becomes upside
Yes,
down.
upside
So you have to imagine.
Yeah, which is the first, because for us,
Yes.
what we encounter first is the critical now, sir. Because
Exactly.
then that do I want to encounter that is my next question.
Exactly.
Or should I not go here? That will determine the exposure, the
Yes.
incision, the cut, and everything determines on that, sir.
Exactly. Absolutely. I agree with you. Always you need to do anatomical position
Yes, yes.
in relation to the patient. I agree with you.
Perfect.
Yes.
So once you have got that,
Yes.
so unless the radiologist is surgeon friendly, they will give every image the same way.
True. Very
For
true.
us, we have to. They will look at the computer monitor. They give a report. They give us small images. We are trying to break a head to see what is inside the small thing.
Very true.
You know,
Absolutely. You have to discuss with the radiologist, and
Correct.
image things are extremely important.
Yes, very
Studying
important.
the image and spending time.
Offline is so important. So because
Correct.
online, then it becomes easy for you. So otherwise, if you have not done that work, then on a table, it's a mess.
Very true.
It's a mess.
I agree with you. Then once you do that, the most next important step is to do the proper craniotomy. Now again, see, there are two things, two types of things. I must confess. See, we all trained in our days till today in many neurosurgeons. They fix the head in the Mayfield.
Correct. Immobilized. Yes, yes.
Immobilized. Somehow for last about 20, more than 20, 25 years, I have stopped.
Stop, sir.
Yes. I don't fix the head at all. Let it be any surgery. I mean, I would like to.
We have also cut down significantly, but we still fix. I can't say we don't fix.
I mean, I want to tell the
Even for aneurysms?
Aneurysms.
Really?
Yeah, 100%.
And even if it's lateral?
100%.
Really?
Yes.
And
you know why?
I agree. But
you know why? Now what has happened is we have good horseshoe, number one. Number two, in those days, there are no hydraulic table systems where you head up,
you have all the manipulations, then the maneuvers are there.
rotate this side,
Correct.
rotate that side, rotate up.
Oh,
now
10 degrees makes such a big difference, sir. When you
now what happens? We strap the patient to the operating table, strap him, okay, and we rotate the table right side 10 degrees to left side depending on your requirement, elevate, depress. That is most helpful in accessing the lesions.
So supine, prone, we have stopped using. We have stopped. Lateral, we are still using.
Yeah. Laterals I don't use.
And how do you use the Lila then?
We put the Lila on the table.
You're using me. You got the other Lila.
Because
we have the Lila that fixes to the
Sugitas, yes. No, again, what happening is, Sharan, the use of retractors is coming down. We put the Lila, the old table mount, and we leave it there. As and when necessary, only crucial steps of we use it. Otherwise, don't use it.
Agreed, sir. But even that, I think we have not considered, changing to that. I'll think about this very seriously.
Yes.
Lateral, in my mind, lateral not possible. You're giving me a new way to think.
Yes.
Let me go do my
acoustics,
homework.
all acoustics.
Really?
All posterior fossa.
Wow. Posterior fossa, okay, sir. Lateral, I'm still struggling with the lateral position, sir. So posterior, even now AAD and all, we are just putting the floating head, all of those things we are doing.
That's right.
Yes. But lateral, thank you. Let me.
And
again, my colleague will be happy because he also
doesn't
like.
The greatest advantage I felt is most important is the time. Fixing the head takes minimum half an hour to 45 minutes. That time is taken off. Post-operative pain.
Bleed also.
Bleed
also. It
also.
It comes
all those things are there. I find, see, I don't want to impose.
I get that.
To the younger generation. But I found out this is more.
Sir, if somebody like you doing 3 to 5, 7 surgeries a day, you're doing this, your outcomes are good, it's at least worth for us to consider it. Maybe worst case, come and see what you do to get the confidence. I think so.
And you start doing it, and you will do it.
Yes, I think so. I think it'll.
So
the moment you put the pin, the BP goes up, sir. Heart rate goes up. Sometimes you've seen that happening.
Very true.
And if the patient is a little light, it instantly goes up. Sir. Instantly goes up.
Very true. Yes. And again, what happens is, if you are not fixed the head, and the thing, just because important question, you can just turn the head this way, turn the head that way, make it back, make it front.
Bit,
10 degrees, enough for you.
10 degrees is huge, sir. So
how
much difference it makes.
Exactly.
Sometimes that small.
So that's what my I learned it, and it went on.
Interesting.
And till today, we don't fix the head. That one thing you asked a question.
Thank you for
Yes.
thank you for
And
that
I leave it to
wisdom.
the younger generation
Thank,
too.
of course, but
It is their
it's something worth considering because a senior neurosurgeon who's doing that kind of numbers to that. I mean, obviously, for my functional, I have to fix it because the move,
for you.
that
It
is,
is
So for that, I will.
you need a less
Yes,
than
yes,
micrometer
yes.
accuracy.
Yes, sir.
That's
Then it's a different thing.
then
With others,
next comes the craniotomy. Craniotomy, depending
Anatomy is opening the skull.
opening the skull.
That's what.
And we have today all the gadgets, important craniotomy sets, of the pneumatic and electrical craniotomy sets. They are fantastic opening, and depending on the requirement, you do the craniotomy, frontal, sides, backwards, size of the clot. Craniotomy can be planned. Now then open to the dura mater and go to the base. Again, except head injuries, I would always advise the younger generation, learn to use the microscopes. Microscope, except head injuries. Always.
So that you get used to using it.
Exactly. Brain surgery, microscope. Now, microscope helped by endoscope. If you learn to use these two things, your results will be phenomenally better.
I agree, sir.
Yes.
Which I agree with you.
Yes. So, microsurgery is the way of life. Your post-operative outcomes, the morbidity and seriousness, the mortality, significantly reduce, and you can give extremely good outcome to the patients.
Agree, sir. Because I think inherently we as neurosurgeons, the way we handle tissue is so different, sir. Actually, if you see the way we respect tissue, the way we have a habit of even handling the outside tissue like we are handling the brain. It's not that kacha kacha kacha. We do that.
Absolutely.
And I think that makes a big difference in the way the wound will heal and everything else. Post-op hematoma, the subgaleal hematoma, to the muscle, to everything, sir.
Absolutely.
I think I agree with you completely that meticulousness at every step is, I think, very important for outcomes.
Hemostasis.
Yes, hemostasis.
Keep the operating area very clean. Respect the blood vessels, respect the brain, respect the vein, and respect the structures. And this will come only with illumination and magnification. You get that. So once that is done, your results will be phenomenally good. You avoid inadvertent injury to the important perforators, veins in the base of the skull, nerves in the base of the skull, and arteries in the base of the skull. So ultimately, the result will be good for the patient, safe and comfortable.
Agree, sir. In fact, when I would keep on seeing microscope, a lot of other surgeons say, why can't you use a loop, operating loop? And in fact, initially I had never used a loop. So I didn't know what a loop was. I mean, in a sense, I thought. Then one day I said, okay, give me that loop. I just go to see what is the difference. It magnified a little bit. But so big difference you cannot imagine. First of all, the light is here if you want extra light.
True.
Now that light will go everywhere you go. You have to keep on adjusting your head to make sure the light falls properly.
Very true.
Chalo, you have fixed that also.
True.
But then I realized, sir, surface, it's okay.
Yeah.
The moment you go in, the game is not even comparable, sir.
100%.
Then I told them, depth illumination and depth perception, only microscope gives us.
100%. You hit the nail on the head.
Don't you think so? So it's
100%.
such a difference, sir, with that depth perception. Otherwise, you cannot even know sometimes how deep you have to go, sir.
Very true.
Yeah.
And today's microscopes, we have 3D perception.
Absolutely.
Number one,
Absolutely.
beam splitting.
Yes.
And we have the resolution.
Correct.
And we have the
angio, the ICG, so many other things.
Exactly.
Yeah.
And this ICG,
Correct.
fluoroscopy, and other. And we have this one, magnification going up to 25 times. 25x. So this makes your results very safe to the patient.
When we also run this business of Neurosurgery, the neuroscience company.
Yes.
So when my guys ask me, how do you think? I said, see, I think like a surgeon. Every time I have a problem, I zoom out.
Yes.
I look at the whole picture, zoom in again.
Exactly.
So that same technique I use in business, sir.
Yes.
The moment we don't know something's going on, we zoom out, look at the bigger picture, then slowly we zoom back in. Sir.
Exactly.
I said, you do the same thing to the point where you want to do.
Absolutely.
It works so well.
I know. Absolutely. So, younger generation must learn the use of microscope.
Well said.
Today, we have another newer addition, which has come last 4-5 years, is exoscope.
I have not used exo myself.
But it's okay. No, it's not what you call
must.
necessity.
It's not necessary.
It's not a must. But good microscope.
Microscope is off.
With the 10 to 15 times magnification, with the xenon headlight, with the autofocus,
Correct.
is invaluable.
And I think it should be the standard of care, sir.
Exactly.
I don't think you should do anything.
Yes.
Whether brain or
Yes.
spine, I agree, sir. It makes a
You
big
have to
difference.
do the microscope.
And especially when you're drilling, clinoid and depth, no, sir.
Yes.
Every half millimeter makes such a big difference.
Life and death
Life
question.
agreed, sir. Life
You can injure the carotid.
Yes,
you
and
can
that
injure
drill turns at 1 lakh RPM. So,
Exactly.
we don't even know what we'll be doing before
Very
we know
true.
what's going on.
Very true. So then, along with that, when you go to the deeper parts of the brain, microscope, because of its angulation, fixed angulation, you cannot see the
Some
blind corners. There, you bring in the endoscope and see the things and proceed.
I
So
actually was, when Dr. Ravi Mondra was telling me this for the first time many years ago, I said, what, really, Ravi? I mean, I had not used that right angle endoscope and all that, sir. After he showed me that, it's really a blind spot, sir. He said, see, Sharan, let me show you. And he turned it like this. I said, Ravi, I didn't realize this. Sometimes, even after so many years of practice, sometimes you don't realize what an additional instrument can add value
Excellent.
to what, no?
Your
And you
vision.
may use it once in 10 cases, once in 5 cases, but that is critical for that
Exactly.
step, sir.
Exactly.
And maybe even 5-10 minutes sometimes. You don't even use it too much.
Exactly. That's right. Repeatedly, you see, clear it.
Correct.
Like say, for example, epidermoids. Anywhere. They them. They go into
creep
microscope will not show
Correct,
them. You
correct.
put an endoscope, there is some lid, just it easily comes out, peel it off. That's perforators. You just look where it is. That's all it is. You know it that
Agreed.
better. That's
No, I clearly understand. So I was struggling with this because every time you have to buy an instrument, there's a cost to it.
True.
And then you have to convince the management. The question is, should I really use it? Is it just a fashion? Is it really a you have to go through all of that. You have to justify the investment and everything else. And then the cost to the patient. So much goes on today in the world of frugal surgeries. Everybody's, the constraint of the budgets. So yet you want to do a good job. So it is quite a struggle here, sir.
Very true. No.
The luxury of cost of pricing is not there.
True.
That's when, it can be
even for and you're absolutely right. See, what happens is the more the gadgets, more the higher things, more the financial burdens. But for a younger generation, starting their departments, starting their career, simple thing, one good microscope and one good endoscope, more than sufficient.
And a good drill, sir.
Good drill.
Yes.
Good drill. Very important.
Yes.
A good
with
drill.
all the attachments.
Yes. Yes.
They should have all of
That's all we require. We don't require further more than that. Then we have what is navigation, neuronavigation, which is another added safe, comfortable tool for other people to just to give a simile. They may ask, what is navigation to the people? Well, it's like a GPS. Like how you put it in the car, you want to go to Sharan Neuro Center, that takes you to there. Like that, you put the image is loaded into the navigation, and precisely less than a millimeter, you can reach the spot.
So only thing, remember, it's not real time. It doesn't move with the car. We have to keep checking it and doing it. So don't think, so show me the map, how is it moving? It doesn't move like that. So you just have to understand that we have to keep referencing ourselves every once in a while.
Instruments.
You have those markers to do that, I think. So you said, and then obviously this podcast is not for that. The techniques of surgical, the finesse that you need to respect tissue. You already said, you can be a little rougher on the tumor, but definitely nothing on the surrounding tissue. It's very, very critical to spare everything.
Absolutely.
So you have anything to say on how to handle, tissue just a little bit more so that people get it. That can be used in any surgery, sir.
Yes. That's a very important question you asked about. The most important way of handling the tissues, Sharan, is surgeon himself need to be extremely patient. My attitude, our attitude, don't look at the watch.
I agree.
Don't look at the clock. Don't look at the
I agree.
time what you are.
Nobody realizes this, sir.
Exactly.
No, many surgeons don't realize this.
We should never look at the clock. Be focused, be patient. Because heart surgery, brain surgery are extremely detrimental to the patient.
You've done wrong.
If something goes wrong, things can go in different way. So your time, your focus, your patience is most important than anything else.
I'm going to make one statement here now, sir. Go ahead. There are a lot of surgeons who pride themselves on doing things fast. I
Understand.
I'll finish in 1 hour, I'll finish in 1 hour. Sometimes anesthesia is also like that. I tell my guys the same thing. Emergency, life-saving, speed is critical until you decompress.
Exactly.
Then you have time to think and do all of those things.
That's right.
But when you're doing electrosurgery, guys, time is not the essence.
Exactly.
You have to do it well, no rest. So don't think if any of you are a surgeon looking at another colleague and say, oh, he's doing in 1 hour, I'm taking 2.5 hours, it doesn't matter. I'm not saying take 6 hours. That's not what I'm saying. But you have to understand, do it. Sometimes the same surgeon, I said some lumbar disc, there are times I finish a lumbar disc in 35 minutes. Sometimes I wonder, really? Sometimes I go in thinking it'll be fast, it takes 2 hours. Every surgery is different, sir.
Exactly.
So you don't have to say, last time I did in 35 minutes, every surgery is 35 minutes. Not true.
Exactly. You're absolutely right.
And
Yes.
just to have the patient, sir, is saying very critical, doesn't matter. And sometimes, sir, the surgery is done in 2 hours. You take 1 hour for hemostasis.
Exactly.
And you have to patiently wait for the hemostasis.
Wait for hemostasis.
And
You're
if you don't want to
absolutely
open again, you have to wait for that
Yes.
hemostasis.
And it became disastrous.
Yes, disastrous,
to
sir.
the patient.
50 ml is disastrous, sir.
I know. True.
You can't shove in a drain everywhere and come out
True,
like other
true.
people do. We can't do it.
True.
So
True.
these are things which it's very different in a neurosurgeon's world
Exactly.
than in other people's world. So
Yes.
I think patience is the very critical thing you said.
Most important.
Very important.
Because see, what you do today will reflect on the patient for rest of his life. What you say. So you are the person responsible for that.
Agreed.
So take your own time. Just because he does it in 1 hour, I'll also do it in 1 hour. No.
There's no race at all,
No,
sir.
because his skill, his things are different. My skill, my techniques are
It's like Virendra Sehwag and Rahul Dravid, sir.
exactly.
Both played cricket at the end of the day.
Yes, yes.
So you can't say this guy is bad, this guy is good. It doesn't matter.
Exactly. Ultimately,
Outcome.
100 runs here, 100 runs there. That's all.
Correct.
Ultimately.
Correct.
Whatever you do.
Well said, sir.
Patient went home. That's what is ultimately for us.
Yes.
Patient's problem was relieved. Patient's problem was ultimately that's what it is. So that's the one thing.
Tell everybody, don't forget the other works. Forget about that. Forget anything that you have. Once you're in, you're in. It's like the Arjuna and the eye of the fish.
Exact.
You have to be completely focused. That people don't realize that they have the headphone here, they're taking call, they're doing this, all sorts of things. It's not, it can't go on like that.
Sharan, life teaches them.
True, sir.
Life teaches them. You understood?
Agree. Absolutely.
Yes.
Absolutely.
Something sometimes happens, then they realize what they did was wrong.
See, you can't say, sir, a lot of people say, I'm very good in multitasking. So I said, boss, I say yes and no to that. See, if you open your computer 2 screens, at the 2 windows, you can only work on 1 window at a time, sir. You can't work on both windows. You have to go from this window to that window.
Absolutely.
But I said multitasking happens when one of the jobs is automated. It's running at the back.
Exactly.
Like driving. Today, my driving is automated.
Correct.
So then I can do a thinking process because anyway I'm changing gear, looking at it, going because I got so used to doing it at the thalamus level.
True.
But surgery can't happen like that, guys. You have to
Very
be extremely conscious about what is going on.
Absolutely. Next important thing you asked about, sir, be very soft and gentle on the tissues. More than your skills, be very soft and slow and meticulous in vital areas. You have to be very meticulous. Then, depending on your experience and your skills, tumor can be, because one tumor at this stage, I can take it out in 2 hours. Same tumor, a younger fellow can take 4 hours. Doesn't matter.
Doesn't matter.
Doesn't matter.
Doesn't matter.
But be soft. Basic requirement is that.
It's like driving the car. So vehicle for
Exactly.
the first time, you will not be going 100 kilometers per hour. You are
Exactly.
wondering whether I'm going to go 10 feet.
Yes.
Then go from the first gear, second gear, third gear. It's the same way, guys.
Yes. So be very soft, very gentle, and patient. Now, most important, again, here, what I see in my life, what I have heard from many people is that as a surgeon, you must remember you are captain of the team.
Correct. Agreed.
You are a captain. Never, ever lose your cool, your temper
Thank you for saying that.
on the operating table.
Thank you for bringing that up.
Yes.
Thank you.
Thank you.
Agreed.
Most
Agreed.
important.
Agreed.
Yeah. If you get disturbed because of so many reasons go wrong, it 100%.
It will, sir.
It will.
It is a surgery.
Exactly.
It's like driving in Bangalore traffic. You'll lose the time because somebody comes, one Kohli will come, one ML. What you'll do about it, sir? At the end of the day, they're not designed to come. They're going to come. What is going to
Yes.
happen is going to happen.
Exactly.
Ah.
Don't lose your things. Yeah. Something goes wrong, be patient, be calm, tackle it. If there is a bleeding, you cannot shout at the sister.
Or anybody, sir.
Yeah, for assistant, because you are operating.
Sir,
You have caused the
I
bleeding.
have seen surgeons throwing instruments.
Exactly.
I said, damn it, you need that instrument in the next 2
Exactly.
minutes.
True.
Who is going to clean that up?
Very true. True. You are the surgeon, caused the bleeding. Then why you blame?
Exactly.
Why you shout at the nurse?
That's incompetence, sir.
Why you shout at the assistant?
I agree,
No.
sir. I
By
totally agree with
by you doing that, they lose their mental stability. They start making mistakes. For mistake what you have done, they start making mistakes.
I
So
agree, sir. And they'll start handset, they'll drop instrument, they'll do all of those things, and brain will stop working after some time.
they give wrong instruments.
Yes.
You got it.
Absolutely.
So
sir.
the whole
Absolutely.
surgery is like a music.
Yes.
Somebody has to play the flute. Somebody has to
Symphony,
play
it's
the
like a
guitar.
Symphony. Correct.
Symphony.
Correct.
Somebody has to play tabla.
Correct.
Somebody has to play the violin. Somebody has to sing.
And
Then-
all of them should know when they should do it. And
Yes. Then only it becomes a music.
Correct.
If something like this happens, it becomes a noise.
Correct.
So
Well said.
and you are the ringmaster there.
Correct.
And if you make a mistake,
Yeah, you can't blame anybody.
everybody makes mistakes. So these are my what you
Beautiful.
call- my
yes.
my thoughts
Yeah,
about
very, very, very well articulate thoughts, sir, because the moment you are sitting in the driver's seat, you are the driver. You can't blame anybody else for what is happening.
what
and,
happens. Yes.
Yeah, and you have to be prepared for the unexpected and things like
And
this.
believe me, Sharan, in last 35 years, I've been following this till today.
Excellent.
I don't remember shouting at my nurses, shouting at my assistants for mistakes which I have created, mistakes which I have done. Never did that.
Well said, sir. Well
And this
said.
is what our people, younger generation, need to learn.
Thank you. I think
Very clearly, I would like to, very dogmatically, I'll mention, you want to increase your performance, keep your mouth shut.
agreed.
That's all.
Agreed.
You want to increase your performance, keep your mouth shut.
So
Keep quiet.
I myself have seen, sir, sometimes something happens outside in the ward, something which you didn't want to happen. If I carry that inside, no, sir, I am disturbed. And a couple of times I realized, why am I doing this? Then I realize I'm carrying some other nonsense inside.
Inside, exactly.
And so, many years now, I make a conscious effort, leave everything behind and come in.
Exactly.
Come in with a clear mind.
Yeah.
What is the goal? What is the agenda? And get it.
And for me and for you, when you enter the operating room, it's like temple to us.
Agreed, sir.
And
I was just going to say,
patient
yes.
is a god.
Yes.
He is a god.
Yes.
You got it.
Agreed.
And next, patient is a god. Patient is my sister. Patient is my brother.
Correct.
My father.
Correct.
My mother.
Correct.
That's all you carry it along
You
with.
do the best you can. I can't say that we'll succeed all
You're
the
not a
time.
god.
But yes.
You're not a god.
Agreed, sir.
You can't play a god, rather. But what is to be done best at that juncture, from as you asked me a question, from the beginning to the end, these are the,
Agreed, sir.
you follow them, even though your skills are not good, you will do well.
Agreed, sir. Agreed.
Thank you, Sharad,
So,
for that.
one more thing I want to say about the way you said about handling tissue. I tell my boys, when you operate, even people watching you should enjoy yourself.
Exactly.
The way your hand is
Yes,
moving.
yes.
Don't you
Yes,
agree, sir?
100%.
It should look so beautiful, so elegant for people to see. You can't be
100%.
doing this. Somehow I don't like, your field should be clean. You layer it up nicely. It should look, I don't know, sir. I'm very sticky about all those things, covering with gauze, covering here, keeping this open,
I'm also like you. That's
removing the
and
dust. Small things, but
100% I agree with you.
uh,
These are most
these are
important
most important.
things which help to patient to come out well.
Yes, the infection risk becomes lesser.
Exactly.
The wounds heal
Heals
better.
better. Yes.
I agree with you, sir. I totally
These are
agree.
the important, what you said.
Nuances,
Absolutely
the
very
nuances
important.
of
Nuances.
any good, sir.
Yes. Apart from that, we have skills. We have this.
That's a
We
lifelong.
have
Yes,
we
yeah.
have that and all.
The
You have
passion, yes.
instruments. That you have
Yes.
navigation. We
Yes,
have debrider. We have QSA. We have that.
Correct. And you should know when to use which instrument.
Which instrument?
Yeah.
to use.
Sometimes when you was talking about the bleeding and all, sometimes if you don't know what's happening, I just put a cotton, take a deep breath, breathe, take three good deep breaths. And just doing this can actually clear your mind.
Exactly.
Don't you agree?
100%. 100%.
Just that few seconds will make a big difference.
Yes,
and
sir.
you can get
Well,
back.
just to share an example.
Sure,
A
sir.
very important topic you brought out, especially in aneurysm surgery. When you are dissecting the aneurysm, nearer to the aneurysm, around the aneurysm, it ruptures.
Aneurysm is like a bleb onto a blood vessel which bursts and can cause a massive brain hemorrhage. We have to do a series on that later, but anyway.
Subarachnoid hemorrhage. So, during dissection, aneurysm ruptures. See, many times, you I'm sure you've heard or you've seen that the whole thing goes panic. Everybody starts jumping, everybody starts doing it. But my philosophy, see, I have crossed now nearing about 2,600, 2,400 to 600. That was in 2024, 2,400. Now I'm nearing about 2,500. I have had nearly about 150 or 160 intraoperative ruptures during the dissection, during the so many reasons. I learned a lesson, philosophy of managing these things. The most important philosophy I need to understand as a surgeon. This is the fellow whom you are operating, survived the aneurysm rupture when his skull was closed.
I never thought like that. Very interesting. Agreed. I get what you're saying. I completely get what you're saying.
Okay.
Correct.
Now he ruptured his aneurysm when the skull is open. Why do you worry?
Correct. You actually have access immediately.
Exactly. See, God has saved him. Nature has saved him when the skull was closed. He has come to you. Now he is ruptured because his skull is open. Everything is there in front of you.
Well said. Well said.
So,
well said.
Organize yourself. See the situation. What is your necessity, skills you are handling? You tackle the situation. Don't jump around. Don't scream around. Don't lose your patience. Still, you be the focused way, what you are focused way, and tackle it the way you need to. Every aneurysm rupture is a different.
Correct. Every story is different.
So, what is the necessity to be done there? You do it. You'll be 100% all. In my life, with so much of this aneurysm ruptures, very rarely we have lost the patient. Number one. Number two, aneurysms from middle cerebral artery, aneurysm from anterior communicating artery, aneurysm from vertebral artery. They are end arteries, small vessels. Internal carotid artery, basilar artery, they are big vessels. They cause trouble. Aneurysm from DACA, distal anterior cerebral artery, aneurysm from middle cerebral artery, they don't cause any trouble, ruptures. Only thing your actions, your reaction causes that trouble.
Agreed.
So, That's what my philosophy is. So
Thank you for bringing this up. Agreed, sir. There's a topic that I didn't realize we will talk, but very nice that you brought this up.
thank
Very
you,
nice.
Sharad. Thank you.
I'll tell you what I am thinking. You saw me in introspecting when you're talking. When I was training, there were enough papers that came out which said intraoperative rupture increase in mortality 3 times, 2 to 3 times. You remember those were the, and that was in my mind like, like this. I said, oh, another madly intraop rupture should not happen.
Akbar
You
to.
understand?
Yes.
It was like that. And every time something would happen, that whole story would, but over time, like you said, sir, it's not bad at all.
Exactly.
And then when I started seeing, I said, then that reassurance came, it's okay.
Yeah, it's okay.
And outcomes were not in any worse, sir. Forget about bad.
Exactly.
You just clean up the blood. Only thing
Yes.
you have to make sure that you clean up all the blood that's gone out.
And wherever it is that you clip it.
Yeah,
That's all.
but you clean up the blood for the vasospasm not to kick in
Yes.
and create any problem for you.
Exactly.
But that's what I was thinking. But
Yes.
how, as everybody, who published it at that time was that reality.
True.
That really doesn't have to be the ultimate reality at all the time.
Exactly. Very right.
Yeah.
It all depends on person to person,
Yes.
how they react. But
Agreed.
our my thought.
No, I subscribe to what you said.
Yes.
I
True,
subscribe to what you
understood,
said.
yes.
Eventually, the destiny will determine everything else for the patient.
Yes.
And for
You
us,
do
but-
what is necessary.
Yes, what
and
is the best we
Don't
can.
jump around. And think that his skull was closed, he survived.
That
His skull
an
is opened
interesting
and he's breathing. Why do you worry?
And when
Wait.
you're seeing it already.
Already.
Yeah.
Wait.
Yeah.
Blood is coming out. Wait. Clean the blood. Clean the blood and see where it is bleeding.
Agreed.
Don't coagulate here. Don't coagulate
don't
there.
blindly,
Don't
yes.
blindly coagulate. Use the clips.
True.
Use the clips.
Temporary claims.
Temporary
yeah.
clips. Temporary clip application is not dangerous. So
True.
one by one. If you
Okay.
coagulate,
Put, remove, it doesn't matter.
if you coagulate, it's permanent.
Correct. And that's the day the disaster happens.
Disaster comes.
And many times in an arterial thing, coagulation is not going to solve any problem.
Exactly.
It's only going to make
Right.
it
You
worse.
will be coagulating
Exactly.
wrong vessel rather
Exactly.
that way.
Doesn't work.
That
I
way,
agree,
that-
sir.
Yes, thank you, sir.
Sir, now the last part of the segment is
Yes.
we spoke out about SRS pre also.
Yes.
Suppose there is a set of skull-based tumors that come in early. That's what we are promoting people to come. Not big enough to operate, or patient is too sick to operate, or you did operate but it's too critical, so you may not be able to remove completely. Something has to be left behind. So when I was training in Japan, where they were very big in Gamma Knife at the same center, Tokyo Women's, the operating neurosurgeon and the Gamma Knife neurosurgeon used to sit together pre-op, sir. And they will tell the patient, see, you have this tumor, this is the risk. I'm going to remove 60-70% safely. We'll try to remove as much as possible, but in case we cannot, for any reason, we don't want a deficit, then the rest of it will be, the Gamma Knife radiosurgeon will take. This is how they would sort of give that,
Right.
so that they don't say that he couldn't remove, so this happened. That story that goes
That's
on.
right. That's right.
So, what is your take in the future of skull-based surgery, especially in people with early diagnosis, completely preserved, and things like that? What would be a role of a non-invasive procedure? What would you think, sir? How do you see it?
I 100% agree with you. No doubt about it. A small lesion in a vital location and important, eloquent surrounding areas where surgical intervention is going to be more detrimental than the natural history of the tumor. Better use non-invasive modalities. What to have? SRS, Gamma Knife or CyberKnife, whatever. They are definitely beneficial. As you rightly said, indicated patients,
Patient selection. Yeah.
patient selection, and you can do
Elderly people.
elderly,
Medically unfit.
yes, medical comorbidities, and other existing medical diseases. Patient doesn't want surgery. Those issues you can do it.
So SRS is called stereotactic radiosurgery. We're
Sir.
going to come up with a series on that in the future. So keep tuned in for that. Dugani sir, it was an amazing chat. I hope you loved conversing it. I think we had a great time. We covered much more than what I thought we would be covering. And I think the emotion, the modulation of what you have covered just reflects what you have done. You've been there, done that, and you have so nicely shared from your life, and people will get, that here is a man who really, I can't say I would like to say your destiny's child, but you didn't shy away from all that was in front of you, all the uncertainties. So those things that you did in Hubli when you came in was gutsy, sir, to say the least. I know as neurosurgeons, we get that guts as inherent part of what we do, but I think everybody may not do that much more. So, I would have done if this was there. I would have done that if that was there. I think you have really demonstrated, through your sheer grit and this one, that what is possible to make. Now you see, sir, why I said this episode is mission impossible. Here is a man who made the mission impossible possible, sir. You have rightfully deserved what I said in the beginning. It's not to make you this one, but truly to reflect who you are being and what you have done.
Thank you, Sharan. Thank you very much. But let me give little my thoughts on
Sure, sir, please.
what we have going through, what you are doing it for this neurosciences subject is something phenomenal. It is only possible with your passion. You're not getting anything back from
No, sir, no.
this. You're not getting any type of benefits from
No.
this. You are spreading the knowledge. You are spreading the information. You are spreading the techniques. You are inspiring
True.
the patients, and you are inspiring the families.
Correct.
You are inspiring the patients.
Correct.
It's a wonderful,
Thank you, sir. Thank you.
wonderful endeavor what you are doing. And today, let me be very clear in this, that you involved me in this endeavor of yours. A small addition from my side in your endeavor. I'm so glad and so happy to be with you and be a little part of your. Please continue this.
Will do, sir. Will do.
Continue this. This is going to take a very, very long way all over the world, not only in India.
True, sir. True.
All over the world, the younger generation need to see this and adopt your qualities, adopt your zeal, I would say, adopt your mission of neurosciences. And definitely, it's going to help the many sectors, help the patients, families, society, and health providers. We are health providers.
Absolutely, sir.
All the
Absolutely,
ways. Not only neurosciences. Any other specialty sees what you are doing, they'll be inspiring.
True.
They may start doing this in their own way.
True.
Number two, in this endeavor, what you gave me an opportunity to, what you call, share and spread it to the world, that you said we're going to Hubli and small.
How many Hublis are there in India, sir, which needs Dugani, sir? Tell me, sir. Don't you agree?
Many are there.
Many, sir.
Many. Are there. That's what I was coming to. Younger generation today, that available technology, available instruments, internet, available the medical facilities. What you are doing in A town, you can do the same things in B town, you can do the same things in C town. Only thing what you need is what you have. Commitment, passion.
Thank you, sir. Thank you so much. Thank you again, sir.
Wonderful time,
Yeah.
Sharan. And I remember this time for a long time.
I'm so happy.
And anytime in future, if I am of any requirement.
Of course, sir. We'll take topic by topic, and then because we can't, if you talk everything together, people will get confused, sir.
Exactly.
They don't know what to do. That's
Yes.
why I said I should take one item, drill it, and give both the emotion and the logic and the practical things, so that they know. We're not coming here to tell you that he'll show you how the surgery is done. That's not the goal of here. We want to make sure there are enough people like Dr. Dugani and us who can make a difference here. Please trust us. Come in. Yes, plus or minus will happen. That's a part of life at the end of the day, but that's what it is. So before I wind up, guys, don't forget to subscribe to our channel, YouTube channel, Instagram, Facebook, comment, like, share, press the bell icon. We've written a book called Rebooting the Brain. That's our first book. That's available on Amazon. It was an Amazon bestseller. Don't forget to read it. It's written for the public. We have a second book which is behind Dr. Dugani called Neuro Justice. That is a 4-volume book trilogy with a handbook written for the judiciary to know how to handle, disability in motor vehicle accident cases. We have a documentary called Rebooting the Brain. So much information is online. I want to end with a very simple thing. What's the importance of this podcast, sir? Yesterday I was having an online talk with the Vice Chancellor for Senior University in Kerala. So I was just trying to make him understand what is the average people's info, like that PhD from Dharwad, information of neuroscience. I asked him, sir, do you know what is a stroke-ready hospital? He said, Dr. Sharan, I'm hearing it for the first time. So can you imagine, sir,
that's right.
how, I mean,
You need to go further. How much you need to do it.
I said, sir, imagine, sir, you're sitting in that chair. You don't know what is a stroke-ready hospital. Forget about which is next to you. So guys, our first episode is that we have practical, ground-level information, like this simple information for you to know, so that you're well informed about it. So when a crisis comes, you're not shutting down and not knowing what to do. So thank you very much, sir, again. And
Sharan, it's a pleasure and honor.
thank you, sir.
Thank you. Thank you.
So as a part of our thing in the podcast, we give a gift our every speaker this book.
Oh, thank you.
Rebooting the Brain. This is your copy.
Yes.
Please do read it, sir. And
100%.
give us a feedback on that.
100%. I'm honored.
Yeah.
I'm honored, Sharan.
Thank
and
you, sir.
congratulations.
Thank you so much.
Congratulations.
Thank you. In fact, Professor Laligam Shekhar has written the foreword to the book.
Oh,
sir.
wonderful.
Yeah.
Wonderful.
Yes.
You can imagine.
Yes.
Then you can imagine.
He
It's
loves the work that I'm doing in functional neuroscience because he lost his brother for a head injury, sir.
Really? I know.
Yes.
I remember that.
Yes.
Yes.
So he
I remember.
has a very soft corner for this.
Okay.
So that's why he does.
Very
That's
nice.
your copy. You can keep
Thank
it,
you.
sir.
Thank you, Sharan.
Welcome.
Thank you very much. Thank you.